COVID-19, today's hearing is being held remotely. All members and witnesses will be participating in or via video conferencing. For the witnesses and all the members, you will need to unmute. Remember that you will need to unmute your microphone when you wish to speak and when you're recognized. So please remember that. I'll kindly remind everyone, but know that you are muted now, and when you speak, you will have to unmute. Documents for the record can be sent to Megan Mullen at the email address that we've provided to your staff, and all documents will be entered into the record at the conclusion of the hearing. The chair now recognizes herself for 5 minutes for an opening statement. My colleagues and witnesses and those that are listening in to our hearing, our country is in pain. Our country is grieving, and our country is angry. Over 2.1 million Americans are sick, 44 million Americans are jobless, and most tragically, we've lost over 116,000 of our fellow Americans. The United States of America has more reported cases of COVID-19 and more deaths than any other country in the world. And this pain falls most heavily on communities of color. And that's why we're having this hearing today. The COVID mortality rate for Black Americans is 2.3 times higher than the rate for white Americans. Other groups are disproportionately impacted as well. For example, in my region in Silicon Valley, Santa Clara County, 24% of the county's population is Latino, but Latinos represent nearly 32% of all COVID deaths. While this virus is new to our country and the world, the plague of racism is not. According to the CDC, Black Americans are more likely to die at early ages from all causes. Black Americans are more likely to die from heart disease or stroke at a young age. As we know from our subcommittee's work, Black mothers are 3.5 times more likely to die during childbirth, even when they have higher incomes and more education than their white counterparts. In the wake of the murder of George Floyd, we must acknowledge the public health impact of police brutality. According to the National Academy of Sciences, 1 in every 1,000 Black men can expect to be killed by police. Black men are about 2.5 times more likely to be killed by police over the course of their life than white men. Our expert witnesses, Dr. Boyd and Dr. Brooks, describe the interaction of racism with COVID-19 as a pandemic within a pandemic. Sadly, the administration has failed to anticipate, track, and respond to the pandemic's effect on communities of color. The latest example of this failure is a final rule issued last week by the Department of Health and Human Services that repealed non-discrimination protections for individuals with limited English proficiency, LGBTQ people, people with disabilities, and women. Another example is that 2 months after Congress passed a law requiring the administration to provide COVID racial analysis, the CDC finally announced that it will require COVID testing labs to report demographic data. However, that demographic data will not be required until August 1st, 8 months after we first learned of this disease. So my colleagues on the subcommittee, led by Congresswoman Robin Kelly, chair of the Congressional Black Caucus Health Brain Trust, have introduced the Equitable Data Collection and Disclosure on COVID-19 Act in response to the administration's failure to act. I have about a minute and a half left, so I'm just going to say that there's so much more work that Congress needs to do to deliver on the belief that Black lives matter in healthcare in our society. And I look forward to hearing the witnesses and what they suggest to us. A vital part of the work will be the newly formed Energy and Commerce Racial Disparities Working Group, and I'm pleased to yield the remainder of my time to its co-leader, our colleague, Representative Yvette Clark, to announce their work.
Let me thank Chairwoman Eshoo for convening this timely hearing today and to discuss the racial disparities that have been evidenced by the COVID-19 pandemic, and thank all of my colleagues and our witnesses for being with us here today. All across the nation, we are currently in the midst of a time of reckoning. For years now, issues of health disparities in the United States have been simmering beneath the surface of public discourse. But in these past few months alone, we have seen in no uncertain terms the ways in which Black, Hispanic, and Native Americans have faced the brunt of this pandemic. We must work together to find a solution to these disparities. And that's why I'm proud to co-lead the Racial Disparities Working Group, along with my colleague, the chairwoman of the Health Brain Trust of the Congressional Black Caucus, Representative Robin Kelly of Illinois. The working group will raise awareness, find solutions, and address racial inequity within the jurisdiction of our committee. It is my hope that the Racial Disparities Working Group will be a major step along the road to racial justice as we embark once again on a mission to achieve equality and equity. I look forward to working with all of my colleagues on these important issues and to hear from our witnesses today. With that, Madam Chairwoman, I yield back and I thank you for the opportunity to address the committee today.
Thank you. The gentlewoman yields back. The chair now recognizes Dr. Burgess, the ranking member of the Subcommittee on Health, for 5 minutes for his opening statement.
And I thank the chair. And as the chair will recall, I sent a letter last month requesting a hearing to address the issue of racial and ethnic disparities in this novel coronavirus environment. And I want to thank you for honoring that request by calling this hearing. This novel coronavirus, along with the deaths of George Floyd, Ahmaud Arbery, Breonna Taylor, Patrick Underwood, and David Dorn, have reminded us of the importance of addressing the realities of race within our healthcare system. I began my medical career at Parkland Hospital. I saw firsthand the challenges of caring for a primarily Medicaid and underserved population. Last week, Michael Horn, the chief executive of the Parkland Foundation, and Dr. Fred Cerise, the chief executive of Parkland Hospital in Dallas, wrote an opinion piece that hit home for me. Let me share some of their words with you. I'm quoting here. This work, our work of healing deep-seated wounds, necessitates that we deliver our healthcare service upon foundations of care, compassion, and community to provide excellent clinical care, to approach that care with compassion, literally translated to suffer with. We have to make it personal and to be connected to our communities. Removing real and perceived barriers, we must actively seek to build relationships across lines of difference. It is only through proximity that we can understand the challenges that we must confront, close quote. And then on Sunday, I was surprised to read another opinion piece from Dallas County Commissioner John Wiley Price. And typically I don't agree with Commissioner Price, but I found myself in agreement with most of what he had written. And he said the discrimination that exists in the 1960s was often very overt and extreme. And as a result, it appeared to be far easier to determine who was racist and who was not, close quote. And then actually he went on to observe at the end of his article that we all ought to bear in mind what we'd learned from our mothers. Do unto others as you would have them do unto you, and try to put yourself in the shoes of the other person. So we are here today to listen. We have a chance to make a difference and to change things for the better. I hope this discussion today moves us in that direction. We should use this information to draft common sense, bipartisan legislation that can actually become law. I do want to remind everyone of the work that this subcommittee has done this Congress and the last Congress. We passed an authorization to increase research for sickle cell disease, which President Trump signed into law in December of 2018. This is the first standalone sickle cell authorization that I can remember in my congressional career, and the first authorization since one was tacked onto a tax bill in 2004. So this subcommittee did that work and got it across the finish line, and then eventually got it in for a signature. Since then, I've spoken with patients in National Institute of Health trials and heard of the promising treatments that are in our pipeline. And let's not forget the Preventing Maternal Deaths Act, the first law to address maternal mortality that was signed into law and is enabling states to establish and strengthen robust maternal mortality review committees. And then this Congress, the Energy and Commerce Committee, has approved two bills, H.R. 4995 and H.R. 4996, that would further address maternal mortality and racial disparities in pregnancy outcomes. This is not the time to take our foot off the gas. I've read articles about the disproportionate impact of coronavirus on racial and ethnic minorities near my district in the Dallas-Fort Worth area. It is possible that we do not even know the full effects because some of the data is either missing or not collected. I do worry about the convergence of the novel coronavirus in individuals who are suffering from other chronic conditions such as diabetes. There is so much we do not know about the biologic behavior of this virus. We are learning new details every day. This is a critical hearing because there is a lot to unpack and about the disproportionate impact of the novel coronavirus on racial and ethnic minorities. And again, to the chair, I once again appreciate my appreciation for your working with me to call this hearing and committing to a productive hearing and all the agenda of this subcommittee. And I would ask unanimous consent that the articles that I referenced, the opinion piece by Dr. Cerise and the opinion piece by Dallas County Commissioner John Wiley Price, be included as part of our record. And I yield back my time.
Thank the gentleman, and all documents where there's a request to be placed in the record will be taken up at the end of the hearing. It's now a pleasure to recognize the chairman of the full committee, Mr. Pallone, for his 5 minutes of questions. And please remember to unmute.
Thank you, Chairwoman Escher, for convening this really important hearing that confronts the alarming racial and ethnic disparities in the COVID-19 pandemic, as well as the inequities within our larger healthcare system. Today's hearing comes at a time of reckoning for racial justice in America, as the Black Lives Matter movement works to bring about structural change, including addressing police violence in America. We're also faced with a public health crisis that is disproportionately afflicting communities of color. And we've long known that people of color experience disparities in healthcare in the United States. While we've made progress to close these gaps in recent years, including with the passage of the Affordable Care Act, people of color in America continue to experience disparities in care and worse health outcomes compared to white Americans. And these long-term trends are rooted in several social determinants that are often driven by structural discrimination and institutionalized racism, which has created systematic health inequity. The tragic result of these long-term trends is that people of color are more likely to suffer from underlying health conditions, have a much harder time gaining access to care, and when they do, they're far more likely to experience bias, discrimination, and poor health outcomes. And predictably, these factors left minority communities especially vulnerable to the COVID-19 pandemic. In my home state of New Jersey, Black residents account for nearly 20% of all coronavirus deaths, despite representing just 13% of our overall population. And for our neighbors in New York City, Black and Latino residents are twice as likely to die from the virus than their white counterparts. Obviously, that's heartbreaking and demands urgent action from Congress and the administration. Now, over the past few months, this committee has taken steps to better understand and begin to address these health inequities, but that requires data. And unfortunately, we're not getting a lot of crucial data from the Trump administration. In April, I wrote to the Centers for Medicare and Medicaid Services, CMS Administrator Burma, requesting that she make public Medicare data related to COVID-19 health outcomes based on race, ethnicity, and gender. It should have been an easy request for her to fulfill, considering she had publicly committed to releasing that data a week before my request. But CMS's claims data is uniquely insightful because of the agency's use of specific coding. which gives CMS access to information that could inform our efforts to improve health outcomes for communities of color. But unfortunately, we're 9 weeks after my request and 10 weeks after she committed to releasing this data, and CMS has yet to release any of it. So yesterday, I wrote to Administrator Verma reasserting this request. And data is so important to our understanding of disparities. And that's why the committee also worked to include provisions in the Paycheck Protection Program and Healthcare Enhancement Act requiring the Trump administration submit to Congress a comprehensive report on COVID-19 health disparities. But unfortunately, instead of taking this congressional mandate seriously, the Trump administration submitted a 4-page document with a list of links to already publicly available web pages. And again, this is a wholly inadequate response. The House has taken several additional actions in passing the HEROES Act last month, which requires a comprehensive update of the 4-page demographics report and the development of an evidence-based response strategy to reduce disparities related to COVID-19. And the HEROES Act would also require the administration to develop a national testing strategy with specific requirements to help reduce disparities in testing. But unfortunately, as you know, the Senate so far refuses to take action on the HEROES Act. We hope that they will. And finally, while I was glad to see that the Trump administration announced plans for more extensive demographic reporting on COVID-19 testing, I'm concerned that this is too little too late. These new reporting requirements will only go into full effect in August, which leaves me concerned that we may never have a complete understanding of the harm this virus has inflicted on communities of color during the first 6 months of this pandemic. So I'm hopeful that this hearing will help basically another step forward in better understanding and addressing these heartbreaking inequities with both COVID-19 and our overall healthcare system. And, you know, I really, I know several members have mentioned it to me earlier, that the data is really important. So I hope that we see the administration step up on these data problems that we've seen and their inadequate response. But I do thank our witnesses for joining us to share their expertise. I know you have a good panel. Look forward to the testimony. And again, thank you, Madam Chairwoman. And also thank you, Mike Burgess, as well for putting this together. I yield back.
The gentleman yields back. It's now a pleasure to recognize the ranking member of the full committee, Mr. Walden, for his 5 minutes for an opening statement. And remember to unmute.
I should be unmuted. Thank you, Madam Chair, and thanks for holding this hearing. Before I start, I have a question for the chairman of the full committee. As far as I can tell, this is the first we've heard of this new working group and on the Republican side. And I wondered if it will be open to Republican participation or if it's a partisan working group. I believe you're muted, Mr. Chairman.
My understanding was that it was open to and bipartisan. If you're not aware of it, then we'll just have to, find out. I don't want to really interrupt the meeting. I'll talk to you afterwards about it. But my understanding is that it's meant to be bipartisan.
I would hope so, because I think the spirit of this whole hearing is bipartisan. But this is the first week.
So, let's get back to later in the day, Greg, on that, Madam Chair.
Thanks, Chairman. The last few months have seen an unprecedented and challenging time. Americans all over the country are raising their voices to raise long overdue awareness to the systematic challenges facing the Black community in America. Meanwhile, COVID-19 has shaken the very fabric of our country, with more than 2 million positive cases and over 115,000 deaths. There's no question the pandemic has had a disproportionate impact on communities of color, seen primarily in terms of poorer health outcomes, but it's also manifested both socially and economically. According to the data from the Centers for Disease Control and Prevention, American Indian, Alaska Native persons have a COVID-19 hospitalization rate about 5 times that of white people, followed by Black people who have a hospitalization rate 4.5 times that of white people. Hispanic and Latinos have a hospitalization rate 3.5 times that of whites. We know this isn't just an American problem as well. All over the globe, minority and underserved communities have suffered disproportionately from the pandemic. For example, in the United Kingdom, the Office of National Statistics found that COVID-19 related deaths for this ethnic group in England and Wales exceeded those of white ethnicity. In the UK, Black males and females are over 4 times more likely to die from a COVID-19 related death than their white counterparts. The same was found to be true for people of Bangladeshi, Pakistani, Indian, and mixed ethnicities. After seeing these alarming trends last month, Dr. Burgess, the Republican leader on the Health Subcommittee, sent a letter to the majority requesting a hearing on this very issue, including how Congress can help reduce these disparities. And I'd like to express my appreciation to Dr. Burgess and to the majority for having the hearing we're having today. We know that chronic health conditions, older age, congregate living, increase the risk of complications and death from COVID-19. However, these facts do not explain the full story as to why certain racial and ethnic groups have become to bear an undue burden of the public health crisis. We need to better understand these differences in healthcare outcomes and how best to improve them. At a hearing earlier this month with some of our nation's governors, the committee heard the disastrous and devastating consequences of some states actually forcing COVID positive patients back into nursing homes. And we now know that upwards of 40% of the fatalities in America are coming out of our nursing homes. That this misguided policy unfortunately exacerbated the suffering and mortality left in the wake of the virus, and its tragic effects were felt disproportionately across many minority communities. Trump administration has already taken steps to ensure vulnerable populations have access to testing, care, and other critical resources during this pandemic. It's my hope that every member of this committee will be willing to work alongside the administration to address disparities in all vulnerable populations. As we know, for data collection, this has always been a province of the states, and we find that the reporting from the states was lacking. So I applaud the administration for demanding states step forward with unified reporting requirements. The economic downturn caused by the stay-at-home orders and lockdowns has exacerbated the impact of COVID-19 on vulnerable communities. While these policies were needed to flatten the curve and slow the spread of infections, they've had an undeniable impact on minority communities. In fact, a recent study by the National Bureau of Economic Research found that the number of opened Black-owned businesses fell 41%. That's an astounding and very, very troubling number. Open Hispanic-owned businesses fell by 32%, Asian-owned businesses fell 26%, and immigrant-owned businesses dropped by 36%. Many hourly workers have lost their jobs and are without work. Unemployment claims have skyrocketed despite the better-than-expected jobs report for the month of May. We know that unemployment and financial strains are associated with higher stress, increased risk of mental illness, and increased risk for substance abuse, all of which lead to poor health outcomes. So I believe that safely reopening the economy, maintaining targeted social distancing, and focusing resources where they're most needed will help minority communities the most. As I stated in the last hearing, listen, learn, act. As a country, we should be listening to others with different viewpoints and backgrounds, learning about their experiences and feelings, and taking actions to ensure justice and equality are available to all Americans, regardless of skin color. I look forward to hearing on this, and I again thank Chair Eck and Chairman Pallone for having this hearing, and I yield back whatever balance of time I have.
The gentleman yields back. The chair would like to remind members that pursuant to committee rules, all members' written opening statements shall be made part of the record. I now would like to introduce our witnesses and thank them for being with us today, and also for your patience as we had to deal with some of the technological problems at the beginning of the hearing. Dr. Rhea Board is a pediatrician and a child health advocate. She serves my constituents at the Palo Alto Medical Foundation. She has taught on structural inequality and health at Stanford University's pediatric residency program, and she serves on the board of California Chapter 1 of the American Academy of Pediatrics. Thank you, Doctor, for your service as a frontline healthcare worker as well as the work that you do to ensure that the children in my congressional district and our nation grow up healthy and equitably. I now will yield to Representative Barragan to introduce Dr. Oliver T. Brooks, since he serves her constituents as a physician in her district.
Thank you, Chairwoman Eshoo. What an honor it is for me to introduce Dr. Oliver Brooks, the president of the National Medical Association. The NMA is the largest and oldest national organization representing African-American physicians and their patients in the United States. Dr. Brooks is an esteemed physician in my district. He is the medical director and past chief of pediatric and adolescent medicine at the Watts Healthcare Corporation in Los Angeles. He also serves as the medical director of the Jordan and Locke High School Wellness Centers. His resume is very lengthy. He serves as the medical director for LA Care Health Plan, whose mission is to provide access to quality health care for Los Angeles County's vulnerable and low-income communities and residents. He has various appointments to hospitals, including MLK Hospital in my district. And he is the chairman of the Community Clinic Association of Los Angeles County, a group of 30 community health centers in Southern California. Most importantly, Dr. Brooks has been working on the issues of racial health disparities and looking at the racial injustices to our healthcare system for many, many decades. I can't think of anybody more qualified and more important for us to hear from in this crisis that we're going through today. And lastly, he's a graduate of Morehouse College and Howard Medical School, so he brings a wealth of information to our committee. Thank you, Doctor, for your service, for your years of service, and for testifying here today. And with that, Chairwoman, I yield back.
Thank you, gentlewoman. We also want to welcome back to the subcommittee Mr. Avik Roy. He's the president of the Foundation for Research on Equal Opportunity. And as I just said, he has testified before our subcommittee on multiple occasions. So thank you to you, Mr. Roy, and welcome back. Dr. Boyd, you are now recognized for 5 minutes. Please unmute so that everyone can hear you.
Good afternoon, Chairwoman Eshoo, Ranking Member Dr. Burgess, and members of the committee and subcommittee. I sincerely appreciate this opportunity to place the health and well-being of those most affected by COVID-19 at the forefront of our nation's public health response. I am testifying today as a pediatrician who works clinically, a public health advocate who partners with community-based organizations, and a scholar who writes and teaches nationally on the relationship between structural racism, inequity, and health. Racial health inequities and the population-level distribution of infections and deaths related to COVID-19 are alarming. The scourge of COVID-19 is that this virus could have harmed anyone. Indeed, it has stretched across the globe. And yet, because of racism and its pervasive hold on every institution in America, this novel virus has disproportionately harmed Indigenous Americans, particularly those in Navajo Nation, Latinx Americans, particularly those in Tennessee, Illinois, Wisconsin, and New York, Native Hawaiian Pacific Islander Americans, particularly those in California, Oregon, and Washington, and Asian Americans, particularly those in Iowa and Nevada. This is a national tragedy. But altogether, COVID-19 has been the most devastating and deadly for Black Americans. To date, Black Americans have the highest overall mortality rates and the broadest distribution of death. In total, 1 out of every 1,625 Black Americans have died from COVID-19. And compared to white Americans, Black American mortality rates from COVID-19 are the highest right in our nation's capital, Washington, D.C., where they are 6 times as high. But similar racial mortality gaps exist for Black Americans in states like Kansas, Wisconsin, Michigan, Missouri, New York, and South Carolina. As a result, national county level data reveals that the COVID-19 death rate is 6 times higher for Americans who live in areas that are predominantly non-white as compared to those who live in areas that are predominantly white. This inequity is not simply a function of the chronic underlying illness that also unjustly plagues Black communities. And it's not simply a function of poverty. Racial health inequities in COVID-19 are the result of racism. And by racism, I mean the legacies and current practices of racial exclusion, discrimination, disinvestment, and violence that concentrate disadvantage, create adversity, and provide conditions for disease within communities of color, particularly Black communities. These intersecting forms of oppression, all linked by structural racism, are why Black people are fighting for our lives right now. Today, Black Americans are more likely to be the essential workers forced to navigate the workplace hazards of this new infectious disease. At the same time, they are more likely to be killed by the state-sanctioned police violence that renders our communities less safe. Black Americans account for an outsized proportion of the newly unemployed and a disproportionate amount of the chronically underpaid. Black Americans have long held one of the highest all-cause mortality rates of any racial and ethnic group in the nation, and they have newly become the most at risk for COVID-related death. But before COVID-19 was a pandemic, Black Americans were already weathering an epidemic of premature death. Before we were devastated by the public murder of George Floyd, we watched in terror while Ahmaud Arbery was lynched for running. Before Tony McDade was gunned down by police in Tallahassee, Breonna Taylor was slain by police in her own home. Before COVID-19 killed Black Americans at 2 to 6 times the rate of other populations, our tiered healthcare system left Black folks to disproportionately die from all manners of disease. Before gentrification disrupted Black neighborhoods, redlining undervalued our homes. Before Jim Crow terrorized Black people across the U.S., slavery tortured our bodies and fractured our families.
Dr. Boyd, can you just sum up your 5 minutes?
Yes. Racism is making America sick, and it's killing a disproportionate number of our mothers, fathers, aunts, uncles, neighbors, coworkers, and friends. These are members of our beloved communities, and the injustice of inequitable disease is that it is wholly preventable. To address these harrowing inequities, our nation's lawmakers must be bold. We need universal health care, universal workplace protections, expanded federal and state relief programs, expanded access to housing and nutritional programs, equitable access to COVID testing and treatment, and a dramatic reduction of our nation's homeless, incarcerated, and detained populations. We must move to abolish racism from every institution, every practice, every policy, and every social norm in which it operates and too often hides. The future health and well-being of our children and their children will be measured in how well we succeed in this. Thank you.
Thank you, Dr. Boyd. I now would like to recognize Dr. Brooks for your 5 minutes, and thank you for joining us. Please remember to unmute yourself. Dr. Brooks.
Good day, Chairwoman Eshoo, Ranking Member Burgess, and members of the committee and Committee on Commerce and Energy and Commerce Representative Pallone for being on this meeting. Thank you for the opportunity to appear before the committee to discuss confronting racial and ethnic disparities in COVID-19 and the healthcare systems. I am testifying as the Chief Medical Officer at Watts Healthcare Corporation and FQHC in South Los Angeles, and as President of the National Medical Association, the NMA, which is the largest and oldest national organization representing the interests of more than 50,000 African-American physicians and the patients that we serve. As the nation's only healthcare organization devoted to the needs of the African-American physicians and their patients, we are disturbed by the vast health inequities for vulnerable populations. We have been and are on the front lines advocating for patients who face numerous and often insurmountable obstacles to receiving quality health care. Black patients experience differences in access to health care, the affordability of these services, implicit biases by some providers, and limited participation in clinical research, which has consequences around viable medical treatments. We have been studying and reporting on this for decades. As a result of the coronavirus pandemic, a bright light has recently been shown on health disparities that have always existed in America. What the world is witnessing is that Black patients are severely overrepresented among those who have suffered the morbidity and mortality of COVID-19. This pandemic is a painfully fresh reminder of these disparities in our healthcare system that leave minorities behind. COVID-19 has killed more than 115,000 Americans, with the Black community accounting for a disproportionate number. An example of this phenomenon is starkly chronicled in a Washington Post article published on June 12th. Blacks and whites each account for about 46% of DC's population, according to Census Bureau data, yet Blacks account for 74% of COVID-19 deaths. And the wards of the city with the largest Black populations have suffered the heaviest losses. The disparity shows up not only in terms of who gets diagnosed and infected with the virus, but who is dying from the disease. Data from 40 states that collect race and ethnicity data show that white Americans are dying from COVID-19 at a rate of 22.7 per 100,000, whereas African Americans die at a rate of 54.6 deaths per 100,000. For Native, Hawaiians, and Pacific Islanders, the available data in 10 states show percentages of COVID-19 cases and deaths that are 2 to 3 times greater than their percentage of the population. The question is, why are we seeing such glaring differences in who is dying from COVID-19? The CDC has noted that those with hypertension, diabetes, and obesity are more likely to have an adverse outcome. Blacks are 2.2 times more likely to have diabetes, 20% more likely to have hypertension, and 30% more likely to be obese. Right there, we see a problem. However, underlying health conditions alone cannot be viewed as the predominant factor in COVID-19 mortality. Social determinants of health, defined by the CDC as conditions in the places where people are born, live, work, and play, are as important a role in a person's health as genetics or medical treatment. They include intangible factors such as social, economic, political, and cultural structures, as well as place-based conditions, including educational systems, accessible and affordable healthcare, healthy food availability, environmentally safe living surroundings, and well-designed communities. Social determinants of health are an underlying cause of today's major societal health dilemmas, including obesity, heart disease, diabetes, and depression. Moreover, complex interactions and feedback loops exist among the social determinants of health. For example, poor health or lack of education can impact employment opportunities, which in turn can constrain income. Low income reduces access to environmentally safe communities, healthcare, nutritious food, and increases hardships. Hardships cause stress, which in turn promotes unhealthy coping mechanisms. Poor reporting of data, which initially masked the fact that the disease was disproportionately affecting Black communities, remains a problem even as states move to reopen their economies. Today, Americans living in counties with above average Black populations are 3 times more likely to die from coronavirus as those living in above average white counties. The AAP, American Academy of Pediatrics, last year published a policy statement on how racism is a core cause of health problems in adolescents and children. What wasn't it? It wasn't race. The paper drove home a crucial point. Racism, not race, affects health, and race should not be used to explain away disparities in racism. Simultaneously, we are facing another deadly pandemic of police brutality, which is also caused by the common thread of systemic racism found in COVID-19. We have witnessed the killings of Ahmaud Arbery,
Dr. Brooks,
George Floyd, and most recently the shooting this past Friday of Rashad Brooks in Atlanta. These deaths that have taken place in just the past 6 months are added to the countless other Blacks who have become victims of police brutality. Blacks are 3 times more likely than whites to die.
Dr. Brooks, you're almost a minute over, so you need to sum up, please.
Yes,
thank you. Excuse me.
So where do we go from here? We advocate for a health system that protects all people. We advocate for equitable housing, healthy food, healthcare services, employment opportunities, and justice. We call on universal healthcare, call on the federal government to endorse policies that address food insecurity, call on policies that bring more African-American physicians, and decrease the digital divide, and more data on COVID-19. Our fight for a better public health system in the United States must center on fighting for a public health system in which Black lives truly matter. I have a vision of transcending COVID-19 to a healthier Black America and therefore a healthier America, because in the end, we are all Americans.
Thank you, Dr. Brooks. We will now I'll recognize Mr. Roy. You're recognized for your 5 minutes of testimony. Thank you again for joining us, and please unmute.
Chairwoman Eshoo, Chairman Pallone, Mr. Burgess, Mr. Walden, members of the Health Subcommittee, thanks for inviting me here today. The Foundation for Research on Equal Opportunity, or FREOP for short, is a nonpartisan think tank that focuses exclusively on ideas that can improve the lives of Americans on the bottom half of the economic ladder. I welcome the opportunity to discuss our work on COVID-19 racial and ethnic disparities. My written statement contains a more detailed discussion of our findings. In my oral remarks, I'm going to focus on 3 topics. First, I'll discuss the mortality impact of COVID-19 on major U.S. racial and ethnic groups. Second, I'll discuss our research on a critical subpopulation, vulnerable seniors who live in nursing homes and assisted living facilities. Third, I'll discuss how economic restrictions put in place by states and localities have disproportionately harmed minorities. We have good reason to believe that minorities are at higher risk from COVID-19. Severe illness and death from COVID-19 are associated with patients with pre-existing cardiovascular or metabolic conditions like high blood pressure, heart disease, and diabetes. These conditions are disproportionately prevalent in African Americans, as we know. As we've been discussing, the latest data from the CDC indicates that indeed, Blacks represent a greater share of COVID deaths than they do of the general population, even when adjusted for the fact that COVID is more prevalent in cities. Mortality rates are also higher in Native American communities, especially in Arizona and New Mexico. What may be surprising is that whites are also dying of COVID at higher than predicted rates. On the other hand, Hispanics and Asians represent a lower share of COVID deaths than would be implied by their geographically adjusted share of the US population. The likely reason for these differences is that morbidity or mortality from COVID-19 is most common among the elderly. 81% of all COVID deaths in the US have occurred in people aged 65 or older, and whites are the oldest racial group in the US with a median age of 44. Asians have a median age of 37, Blacks 34, Hispanics 30. Hence, we should expect to see higher fatality rates in whites relative to Asians and Hispanics due to their age, and indeed we do. On the other hand, African Americans are relatively young, but we are still seeing higher mortality among Blacks. Here's another way to think about it. Overall, 81% of all COVID deaths have taken place among those 65 or older. But 89% of white deaths are among the elderly, 78% of Asian deaths, 73% of Black deaths, and 59% of Hispanic deaths. On the other hand, overall, people aged 45 to 64 represent 17% of COVID deaths overall, but only 9% of white deaths, 20% of Asian, 24% of Black, 30% of Hispanic. Many of you are familiar with our research on the tragedy taking place in our nursing homes and assisted living facilities. 0.6% of Americans live in long-term care facilities, and yet within this 0.6% of the population lies 42% of all deaths from the novel coronavirus. 42%. As you know, nursing homes are residential facilities for medically vulnerable seniors who have challenges with activities of daily living, such as taking a shower or getting dressed. Nursing home residents are disproportionately poor, non-white, and enrolled in Medicaid. We wanted to see if states with high death rates in long-term care facilities were also associated with higher proportions of Black residents or residents enrolled in Medicaid. As my written statement details, we found no such correlation at the state level. We are working on a county and facility level analysis that may yield greater insight, and we'll be happy to share it with you when it's completed. When it comes to the economic lockdowns that states and localities have imposed on people and businesses in response to the pandemic, there is no ambiguity regarding racial disparities. In late 2019, Black unemployment reached its lowest rate in history, 5.4%. Today, the Black unemployment rate is 16.8%. Hispanic unemployment reached 3.9% in late 2019, also a record. Today, it's 17.6%. In my written testimony, I detail how disparities between white and non-white unemployment rates also reached their lowest levels in history just before the pandemic. But the economic lockdowns have brought those disparities back to levels seen a decade ago. Compared to whites and Asians, Blacks and Latinos are less likely to work in white-collar occupations where working from home is feasible. Instead, they are seeing their jobs and hours slashed. Hourly wage work is down 50% on average and even more in places with the most stringent lockdowns. But Black-owned businesses have been also hit far harder than white-owned businesses. As Mr. Walden noted, it's estimated that Black-owned businesses have experienced losses of 41% between February and April versus 32% for Hispanic-owned businesses and 17% for white-owned companies. Put simply, racial and ethnic disparities are worse when the economy is worse, and especially during the government-mandated shutdowns of the economy we're experiencing today. There is much more to say, but let me stop there, and I look forward to our discussion today. Thank you.
For your testimony, and thank you for it being within the 5-minute time frame. We're now going to move to member questions, and the chair recognizes herself for 5 minutes. Dr. Brooks, when it became clear that COVID-19 was going to be a public health emergency, what, in your view, should have been done to prepare for and prevent the health disparities by race?
First of all, it would have been very helpful to have aggressive testing in the African American community, with the knowledge that there would be disparate outcomes based on the higher incidence of diabetes, obesity, and hypertension. We should have known early on that we needed to test that population. Number 2, we needed to really focus on the access to healthcare and the access for PPE of those that are practicing on the front lines, where these patients would be showing up in the hospital and the urgent cares, such that those treating would be comfortable with those coming in that could possibly have COVID-19. And then lastly, a focus on telehealth, telemedicine, getting access to these patients who have hypertension or diabetes. The studies show that if you have hypertension and have it controlled throughout, you're less likely to have an adverse outcome, the same with diabetes. So those would have been some actions that would have been helpful at the time.
Thank you very much. Dr. Boyd, Mr. Roy, do you want to add anything to that response?
Well, Madam Chairman, I would talk about nursing homes. If we had been aggressive in testing both workers and residents of nursing homes early on and restricting visitation, some states did it, but many states went the other direction. That would have had a big impact because nursing homes, as you know, ma'am, are disproportionately non-white, disproportionate Medicaid enrollees, and that's a population that's really gotten hammered.
Thank you. Dr. Boyd?
Yes, I would add that data that actually came out of your district showed us that, as Dr. Brooks said, African Americans are less likely to be tested, and particularly less likely to be tested in the outpatient setting. So African Americans at higher rates of hospitalizations and ICU visits, likely because as they presented to care, they were not adequately tested and identified and then able to quarantine themselves and not continue to spread in their communities. I'll also say that because we know African Americans make up a disproportionate amount of essential workers, we also needed to distribute, and we still need to widely distribute, universal access to protective equipment, particularly for people who need to work indoors.
To Dr. Boyd and Dr. Brooks, you both make the point that racism, not race, affect health outcomes. How has racism affected our nation's response to the current pandemic? And Dr. Boyd, you can go first.
Thank you for that question. I think what I was trying to say in my early testimony is that racism is really pervasive throughout society. And so that answer is it partly affected it because African Americans were already at higher risk of having, as other folks have said, chronic illness, which is not a function of their race, but is a function of their access to resources that racism shapes, and also had higher rates of poverty, which again is a function of how racism distributes resources by racial group in this country.
Thank you. Dr. Brooks, would you like to add something to that?
You know, I only add that in the early days and even now, the data was not clear. The CDC was not collecting racial and ethnic data on COVID-19 cases, and even now is getting it piecemeal. So there is a feeling that there was just a neglect on getting information about the racial aspect of COVID-19.
Thank you. Well, let's see, I just have a minute, so let's see what else I can get in. These questions are for all the witnesses. You can answer yes or no. Dr. Boyd, would having free COVID-19 treatment available help address racial disparities?
Absolutely.
Dr. Brooks?
Somewhat, but then there's still going to be the access issues with transportation and not getting off from your work, et cetera.
Mr. Roy?
Yes, but I worry that if you just mandate coverage of everything, the providers are off the hook in terms of what they charge. So you have to make sure if you mandate coverage, you also keep an eye on the prices that providers are charging for those services.
I think the issue of federal data collection is really very important. So I'm not going to ask what you think about that. It's been spoken to not only by the witnesses, but by the chairman of the full committee. I think that my time has now, my time is up. And so I will recognize Dr. Burgess, the subcommittee ranking member, for his 5 minutes of questions. And please remember to unmute.
Great, thank you. And thanks to our witnesses for being here with us this morning. Thanks for your time and in helping us in this these evaluations. Dr. Roy, I just need to ask you a question because so much of your testimony is data driven. And then the concern that our information is only as good as the inputs that it receives. So what's your opinion right now of what, both from the administration standpoint, what the states are doing to improve reporting for coronavirus and other health data to ensure the inclusion of racial information?
Well, what I'd say, Dr. Burgess, is that the data collection is improving. We're now starting to see more granular data from the CDC on race, particularly race by age. I testified before another committee, the House Coronavirus Select Subcommittee, a few weeks ago, and we talked about this issue of not seeing age-based breakdowns by race, which is really important because, as we know, 81% of all deaths are among people over 65. So seeing how that breaks down by age, given that the median age of each ethnic group or race is different, is really important. So we're now starting to see that data. The other thing I would say is the nursing home data. States had very different reporting policies of nursing home data. Now the CDC is requiring nursing homes to directly report their fatality data directly to the CDC going around the state governments. And I think that's helping a lot because that's giving us consistent reporting from states like Michigan. Michigan has yet to report on a state basis their data. At least they're only now starting to because the CDC is requiring it.
Well, and thank you. And you know, this committee, the subcommittee and the full committee has a history of passing landmark legislation. One piece of landmark legislation that we're all proud of is Cures for the 21st Century. But having diverse participation in clinical trials, and I know from talking to some of our acquaintances in the pharmaceutical research and manufacturing side, and certainly the language in 21st Century Cures did attempt to improve diversity in medical research. So I guess, Dr. Brooks, if I could ask you, to the extent that you understand what we did in 21st Century Cures, recognizing we'll be doing a follow-on to that bill at some point, Cures 2.0, have we made substantial improvements in including all ethnicities in collection of the data? And do you have thoughts about what Congress, the NIH, and the private sector partners could do to significantly increase diversity amongst clinical trial participants?
So yes, I do believe there has been some movement forward. I'm with a group called the Alliance, and we submitted a letter to the FDA asking for more representation. I think it'll be very important to have representation in clinical trials as it relates to a vaccine that may become available. So I think that some has been done, but there is room for more, and I appreciate where we are at this point, but where we need to be, we're not there yet.
Well, thank you. And let me just say thank you for your service to the National Medical Association. I know how important that is, and I'm grateful that you're doing that. You raised the issue about disparate testing at the beginning of the outbreak of this illness. It's a novel coronavirus. Nobody had ever seen or heard of it before, so no surprise, every aspect of it wasn't gotten right at the beginning. But to the extent that we've learned along the way, and you referenced vaccines and vaccine development, from the standpoint of the National Medical Association, what are you doing currently to ensure that when a vaccine does become available, since we've identified the high risk nature that we're discussing today, what is the National Medical Association doing to ensure the availability of those vaccines when they do finally become available?
So I'm actually on the ACIP COVID-19 work group, which is developing the potential for rollout of the vaccine. And in that capacity, am advocating for ensuring that those at high risk are one of the earlier recipients of the vaccine. I also am crafting message. There is concern in the African American community regarding vaccine hesitancy. Excuse me. So I am ensuring that I study the data and can ensure my constituents in my community that the vaccine is in fact safe.
Yeah, of course, we need to prove that it is safe and effective. That's the first. But I thank you for that. I've got a community, my main county is vaccine hesitancy really across all races is a feature, and it's something physicians have to do our parts in helping people understand the importance not just of a coronavirus vaccine when it becomes available, but even the flu vaccine next fall. It's going to be critically important. So thank you all for your testimony, your participation today. I'll yield back to the chair.
Gentleman yields back. Pleasure to recognize the chairman of the full committee, Mr. Pallone, for your 5 minutes of questions, and please unmute.
Thank you, Madam Chair. And I want to follow up on the data. I know that Dr. Burgess mentioned it, but I just think that data is so important in trying to achieve a clear picture of the problem that we face with inequities. And I mentioned that we did include a number of requirements in the HEROES Act that would require the federal government to better track and more regularly make public racial, ethnic, age, sex, and gender data as it relates to COVID, as well as require the various federal agencies in charge of data collection to modernize the data collection. But unfortunately, we're still waiting for the Senate to act on HEROES. So my questions of Dr. Boyd and Dr. Brooks, I'm going to kind of put it all together, and then if you could just use half the time to respond. In your view, has data on COVID-19 cases, hospitalization, and deaths stratified by race and ethnicity been sufficiently collected and shared to get a comprehensive view of the disparities issue? Is any key data still missing? What needs to change in the process of data collection and sharing to achieve a better information so we can address the problem of disparities? And I guess we'll start with Dr. Boyd. There's about 2 minutes each here to respond.
Thank you for that question. I think one of the challenges at the federal level is that at the local level and at the state level, there are lags in reporting, and there's a different specificity to which various departments report it upwards. So I think one thing that we need is comprehensive data. So you don't just want the racial and ethnic group, as others have said. We need it to be coupled with age, sex, or gender, and also location, the county that you're in, so that we can have an idea of areas that are underserved by our current medical infrastructure. I think when you put those things together, you're able to answer questions like Avik presented, which is like, is age actually a driving risk factor for having COVID-19? And data recently that came out of Harvard's medical school indicated that actually at every age cohort, African Americans and Latinx populations in particular, and for some age cohorts, indigenous populations also, have exceedingly high mortality rates. I think the most devastating data was that at age 35 to 44 in the United States, African Americans have a mortality rate that is 9 times white Americans. This is even for young folks. And you only get that level of specificity that allows us to say something different to the public about who's most at risk when you combine data values like race and ethnicity with values like age.
Well, thank you. And Dr. Brooks, again, particularly what key data is missing, and what do we need to change, particularly at the federal level, to get more accurate data or statistics that would be useful in trying to deal with these inequities?
So I think one piece that is key that we don't have is the rate of testing. We don't have clear data on the racial and ethnic findings of the number of people tested. We have the hospitalizations and deaths, but just tested, for example, what percent of African Americans are testing negative versus positive, and how does that correlate with the other populations? That in and of itself would be very helpful because that indirectly reflects on access. It indirectly affects on insurance coverage and the messaging in the African American community in terms of getting tested. So I think that information would be very helpful. There was data coming out of Connecticut that African Americans had a harder time getting tested. So if we had more data on testing, we'd have more information on access.
Well, can I issue, is this just in order to modernize and get better data? I mean, we can talk about federal, but a lot of this has to be on a state and local level as well, or is it mainly the federal government that has to act?
So there was in one of the recently passed bills, demand that the administration get better data, and they released a 4-page document that really didn't dig into getting the data well. So I think that there should be leadership at the federal level to set particular standards of what data needs to be collected and reported to the national administration like the CDC.
Well, I think you heard me say in my opening statement, I was very unhappy with that report. And one of the reasons that we need the HEROES Act is because the HEROES Act has language that I think does more towards getting to, national standards and requiring the federal government to do a lot of this, or even, get the data from the states and the localities. So again, I think the HEROES Act is really important in this regard. But thank you so much. Thank you both for your input and for being part of this hearing. It's very important. I yield back, Madam Chair.
The gentleman yields back. It's a pleasure to recognize the ranking member of the full committee, Mr. Walden, for his 5 minutes of questions, and please unmute.
Thank you very much, Madam Chair, and thanks to our witnesses. This was really insightful, really helpful information as we're all trying to figure out what we got right, what we got wrong, and more importantly, what do we need to do going forward when a second wave hits, as we should anticipate it will in the fall. And Dr. Brooks, I appreciated your comments about telehealth. My districts would stretch from the Atlantic to Ohio, so we really need to ramp up our access to broadband, our access to telehealth. We did a lot of that in the CARES Act in a bipartisan way for Medicare. It's up to the states on Medicaid, but I think it made a lot of sense. I wanted to ask about the data, because this is something we've all struggled with. And in the CARES Act and other legislation we passed, the President Trump signed into law, for the first time we put some requirements, maybe not as much as we should and need to going forward, but there are data reporting requirements. As we dealt with this onset of the pandemic, I think we were all looking to our local healthcare providers to first. So let me ask, from your perspective in the facility where you are, were you reporting all of these data points? And if so, to whom? Was this to the state of California? Was it on up to the CDC?
So what happened is, for all the testing that we did, it would be reported by the lab to the county. So the county would therefore collect the data. Then what the county did with it, they would report it to California Department of Public Health.
And in that reporting, were you reporting everything to the lab, and then the lab in theory to the county that you now, knowing what we know now, was that fulsome enough? Did you have enough data there? Did it have ethnicity and age and all of that?
It had age, but I believe not ethnicity.
So even the data out of your own lab, your own testing then wasn't comprehensive as we need it to be now.
Well, because in general, lab data isn't necessarily reported by ethnicity. And we were relatively a small in number at that point in time as it began. And so we needed guidance.
Yeah, I appreciate that. And I think we all learned along the way, but it was that area we found. I know that these labs generally didn't collect or report those data. And now we learn that's really important to do, and we need to do it going forward. Mr. Roy, thanks again for testifying. As we address the issues within the United States and minority communities here, and certainly the nursing home issue, I am so glad you raised that. We saw what happened as a result of the governor of New York putting COVID positive patients back into those settings. And obviously he's learned that was a bad idea. But when I looked at the information overseas, and again, just one example in the United Kingdom, Black males and females are 4 times more likely to die from COVID-19 than their white counterparts in the UK. So this is more than just a US issue, and it also found the same thing true for Bangladeshi, Pakistani, Indian, and mixed ethnicities. What is it you're finding in the data about this disease, if anything, that goes beyond some of the topics that have been discussed so far? Is there something else here that we're not seeing if it's happening elsewhere?
So, Mr. Walden, we haven't looked at the racial disparities in other countries besides the United States, but what the CDC has done that's very useful that I don't know if those other countries' data that you're citing do is the CDC data is adjusted for geography. So, for example, we know that about half the deaths from COVID-19 in the U.S. have occurred in the tri-state area around New York City. The tri-state area around New York City is inherently more diverse than the rest of the country. So when you adjust for the ethnic distribution of minorities, mostly who live in cities, that's true in the UK as well, you see that because cities are where the outbreaks are, and there's higher mortality in cities, minorities are disproportionately affected. So you have to adjust your analyses for that factor. And when you do that, as the CDC has done, you still see a disproportionate amount of mortality for Blacks, but not for Hispanics and Asians.
Interesting. And have they gone further to look at why that is? Is it the higher rates of diabetes and hypertension and some of the things we now know this horrible disease virus attacks?
The CDC is not, but one thing I want to point out, and I mentioned this in my oral statement as well as in the written testimony, whites are actually, if you adjust for geography, white mortality is also overrepresented in the US, and that's probably because whites on average are older. So I'd say that the main thing is it's a combination of things we already know, which is age, cardiovascular comorbidities, diabetes, things like that. And then if you live in a nursing home, those are the 3 big correlations that we're seeing. And obviously in certain minority populations, especially African Americans, you see the perfect storm there, or the imperfect worst storm.
I appreciate that. And Madam Chair, I have no idea what time I have left, but I'll yield it back. And thank you again for doing this hearing. It's really been helpful.
Well, thank you. The gentleman does yield back. It's a pleasure to recognize the gentleman from North Carolina, Mr. Butterfield, for your 5 minutes of questions, and please unmute.
Thank you very much, Madam Chair, and thank you to the ranking member for yielding back a minus 10 seconds. But it's good to see all of you today, and thank you to our 3 witnesses for your testimony. Dr. Brooks, I watched your interview with the BNC News Channel. It was very, very enlightening on how COVID is affecting physicians. Not only patients, but it's affecting physicians. My dad was a dentist many years ago, and the National Medical Association and the National Dental Association were sister organizations. And in fact, they often met for their summer conventions at the same time and in the same hotel. And our families look forward to those conventions every year. And sir, you're continuing that great legacy, and thank all of you for your testimony. The killing of George Floyd has finally forced our nation to address racism in policing. COVID is forcing us to confront the impact that racism has on the health of African Americans and other racial minority groups. These dual crises have illustrated what so many of us have been saying for years. The systemic racism and entrenched bias in all facets of our society have not surprisingly resulted in inequities and inequalities from top to bottom. Black Americans face higher rates of poverty and economic insecurity, illness, and chronic conditions like diabetes and heart disease and kidney disease. African Americans also face higher rates of arrest and incarceration. These are indisputable facts. The data show this, and the experiences of our friends and family members prove it. In my state of North Carolina, 34% of those who have died from COVID were African American, despite the fact that we are only 22% of the population. And of the total cases, 44% are Latinx, despite the fact that less than 10% of North Carolina's population is Latinx. We have seen the reports linking kidney disease and its two leading causes, high blood pressure and diabetes, to an elevated risk of death from COVID. We also know that kidney disease had a disproportionate impact on minorities long before the current crisis, but this alone cannot account for these figures. And so, Dr. Board, thank you for your testimony. You note that blaming the disproportionate impact of COVID on communities of color, on higher rates of poverty and chronic illness, ignores the underlying issue of racism throughout our country's history. You also, Dr. Brooks, you also noted in your testimony that in order for us to effectively eliminate the health inequality gap, we must address America's perpetual pandemic of racism and the legacy that hundreds of years of discrimination has left on the health and well-being of communities of color. Dr. Boyd and Dr. Brooks, let me take a look at my time. I'm okay. Dr. Boyd and Dr. Brooks, could you elaborate on this point and explain to us 1 minute each why conflating the effects of racism with poverty is not a good idea?
Okay, I'll go first. Thank you so much for that question. First, not all patients that have COVID-19 are poor, and not all African-American patients that have COVID-19 are poor. So first, it's inaccurate. The other problem is that racism shapes how resources are distributed in this country. And so we have to think about what that means in terms of healthcare service delivery. One example we can use right now is how crisis allocation of healthcare resources during COVID-19 used criteria like life expectancy to determine whether individuals who presented to hospitals who were overwhelmed, particularly in New York, who were overwhelmed with the amount of sick patients, whether or not they got life support. If you use a metric like life expectancy, and we know in this country, African Americans have a lower life expectancy than other populations, a life expectancy gap as high as 10 years between white females and Black males, then you automatically discount African Americans when you're talking about who deserves life support in the hospital setting. So there are ways in which
let me try Dr. Brooks in the 1 minute that I have remaining. Dr. Brooks, why is it not a good idea to combine racism and poverty in the same conversation?
Because studies show that when you factor out income, education, healthcare coverages, and other social determinants of health, African Americans still have worse outcomes. So, in other words, the variable there is race. Two people with the same income, healthcare coverage, and education, you will have African Americans with worse outcomes. This comes into implicit bias as one of the primary causes. African Americans are just treated differently because of how they're seen by the majority community.
Thank you. As both of you can see, 5 minutes goes very quickly. Thank you, Madam Chair. I yield back.
Gentleman yields back. It's a pleasure to recognize the gentleman from Michigan, the former chairman of the full committee, Mr. Upton, for your 5 minutes of questions. Unmute, please. You need to unmute, Fred.
Got it. He states he's trying.
There you go. Oh, no, that was someone else. We can't hear you, Fred.
I'm sorry. There we go.
There you go.
Well, thanks very much for doing this hearing. And you know, it's so critical that diverse populations, especially those with vulnerable populations, be adequately represented in the clinical studies. And the 2020 COVID pandemic has amplified the existing inequalities that place individuals and groups in markedly unequal positions. We know that. We really appreciate the statistics today, particularly even some of the worldwide numbers that you've shared with us. And early reports, of course, of death from COVID have found a startling high rate of mortality among the African American community. So Diana DeGette, my colleague, member of this committee, and I released some initial policy ideas as we've been beginning to consider and update what we did with 21st Century Cures. And Dr. Burgess mentioned a little bit about that as part of our Cures 2.0 process. In the release that we released, the concept report back in March included some ideas on ways to improve healthcare access for diverse populations. We also included some reforms to support the further use of real-world evidence to support the approval and coverage of drugs. And of course, one of the big things that 21st Century Cures did was we expedited the approval of drugs and devices, but we allowed the clinical trials, which were before siloed. They didn't share information with others to really change, which is why when we get a vaccine for this and better therapeutics, we'll be able to get them months, if not years faster because of the work that this committee did in pushing that legislation onward, where President Obama signed it into law back in 2016. So I'd like to ask each of you is we do consider opportunities to provide and improve healthcare access for diverse populations. What are your thoughts on the importance of ensuring that diverse populations are fully represented and not excluded in the healthcare operations, such things as clinical trials? And I guess just knowing that you all control the button, maybe we'll start with Dr. Roy and then Brooks and then Boyd, if you take just a brief time here.
Sure, Mr. Upton. The disparity in how clinical trials are conducted has been a problem since I was in med school 25 years ago. So I'm glad to see some work on that particular topic in Congress. The one thing I would mention on top of that is that it's great that your committee has been working hard to reduce the cost and accelerate the pace of innovation in pharmaceutical development, vaccine development. Well, we also have to make sure that innovative companies are socially responsible in the way they price these drugs, particularly if they're going to be guaranteed decades-long monopolies. So I hope that your legislation will consider ways to think about that problem as well, because that also harms access to drugs for low-income or disadvantaged populations.
Exactly right. And Diana and I, again, are working on that aspect of it as well. It's no good to have a new drug and have no one be able to afford it.
This is Dr. Brooks. I concur with that statement. The National Medical Association has had for years a Project Impact, improve minority participation and access in clinical trials, because we have understood that we needed minority participation. I think that the actions that are being taken are very helpful. I think it's critically important when there are more studies that go forward with treatments for COVID-19, such as hydroxychloroquine, which is somewhat of a non-starter, but remdesivir and other treatments. We had a patient that just had convalescent plasma that got better overnight. So I just want to make sure that there's more access to those treatments.
Great. Dr. Boyd?
Yes, I'll also say expanding Medicaid is really critical. So most African Americans predominantly live in this country in the 14 states that have yet to expand Medicaid. To participate in a clinical trial, many need insurance coverage to actually cover some of the services that they're receiving as a part of the clinical trial. And so the lack of Medicaid expansion disables some African American populations from participating just on the basis of affordability. So expansion of Medicaid would be a big boost.
Well, I thank you all. I've got 30 seconds left, so let me just make a comment here at the end. You know, when we get through this thing, it's because it's in essence really a three-legged stool. We've got to have the therapeutics, we've got to have the testing, and we have to have a vaccine. And I know that as one of the provisions in the last bill that the president signed into law, there was $1.8 billion for the Shark Tank for home testing. And credit to Dr. Collins for really putting together an organization. Literally within 48 hours, they've taken 80 to 100 different entities' applications to see which private sector group may work. In my district, in my state, we have an entity that's actually got a device about this size. It's been patented already. They've worked with 2 different universities. has a little receptacle for both saliva and blood, and it can test within minutes the antibodies if one has been exposed to that. And so far, it's survived the Shark Tank. We're hoping that it may be the big winner, but it's so important because you're going to be able to link that to an iPhone. And so wherever you go, a restaurant, the U.S. Capitol, your school class, your line at work, you'll be able to show that you're green and therefore you've not been exposed to this. And it's so important that we get this into the field, we get it into our homes, because this will be a major step forward in trying to stop this spread. So with that, Madam Chair, I yield back my time, and thank you again for
the gentleman yields back. Pleasure to recognize the gentlewoman from California, Ms. Matsui, for her 5 minutes. Unmute, please, so we can all hear you.
Absolutely. Thank you, Madam Chair. Thank you, Madam Chair, for having this hearing today. I want to thank the witnesses for their enlightening testimony. Police violence and racial health inequities have long contributed to levels of stress, toxic stress in the Black community. In recent months, the police killing of George Floyd and the unjust, disproportionate impact of COVID-19 on Black communities have undoubtedly taken an extra toll on the mental health of Black Americans. In response to the pandemic, we've seen well-resourced providers across the country make rapid shifts to telehealth. In Sacramento, data emerging from our community health centers providing telepsych services shows that no-show rates for behavioral health appointments dropping dramatically. Dr. Boyd, from your perspective, what opportunities exist to leverage technology in minority communities to address mental health challenges? And how do we use telehealth in a way that creates more access and reduces barriers to care without exacerbating inequalities? Dr. Boyd?
Thank you. Telehealth is a great opportunity to reach populations that might have had other barriers to physically receiving their care within clinical settings. But we know in this country that there are wide gaps in availability to broadband internet, Wi-Fi access, and devices that support the type of connection you need to have quality video to make your telehealth visit effective for your care. And so to expand telehealth in a way that doesn't further inequities, we need to ensure that people have access to quality devices and to internet that makes it possible for them to participate in this new form of care.
Certainly, and that is really a focus of our committee moving forward also. Community health workers have proven to be an effective and versatile workforce capable of improving health outcomes for diverse groups. These workers are able to foster the relationship between communities and the healthcare system by promoting trust between patients and providers and ensuring the health system's ability to provide culturally centered care. Dr. Brooks, what value do community health workers provide in the fight against COVID-19, particularly in communities of color?
So what you will find is community health workers are generally very similar to the communities in which they work. So they relate directly to the patients in which they are treating. They also understand, therefore, the misperceptions that may occur, the issues with getting access. So they are crucial. And so FQHCs, for example, are funded for 1 to 3 years. What would be helpful is if FQHCs could get funded for up to 5 years without having to reapply for finances, because that would give us a more strategic planning ability.
Well, certainly that was something that most of us do support here. A recent study by Sutter Health provided stark differentials in access to testing for COVID-19, which ultimately delayed diagnosis and treatment and led to higher rates of hospitalization for Black Americans in Northern California. The study found that Black Americans were less likely to be tested in an outpatient setting before going to an emergency room. Dr. Boyd, what do you believe can be helpful in a situation like this? Most people, unfortunately, go to emergency rooms, even though that is not the most appropriate way. What consequences does utilizing the system in this way have on health outcomes households, and communities? And what recommendations do you have for changing when and where people seek care?
Emergency rooms are the most costly setting in which to seek medical care. In the setting of COVID, when patients may have the acute onset of severe symptoms, that is an appropriate setting to seek care. But what that study found is that most African Americans did not receive a test in the clinic, in the outpatient setting, before they were severe enough to have to go to the emergency room and be hospitalized. So broader access to testing, even for patients whose symptoms might be subclinical, those who are not yet severe. I think early on we've seen we need to know if you have COVID early to be able to treat you effectively.
Absolutely, and that's why we really believe that the setting has to be something that's culturally sensitive too. And in many cases, the community health centers be the appropriate place to do this too. I see my time has gone, and I yield back. Thank you.
The gentlewoman yields back. The chair now recognizes the gentleman from Illinois, Mr. Shimkus, for his 5 minutes, and unmute, please. You need to unmute, Mr. Shimkus. We can't hear you. We can't hear you. Mr. Shimkus, are you still with us? But we can't hear you. Why don't we get your situation straightened out, and we'll the chair will recognize the gentleman from Kentucky, Mr. Guthrie, for 5 minutes.
I think I got it.
Okay, I'll yield back to John and go on my spot.
Okay, thank you.
Yeah. My apologies.
That's all right. You're recognized for 5 minutes.
Thank you very much, and I'll try to be brief. Dr. Roy, I was really interested in the 0.6% of the population having 42% of the deaths, and we all come and bring our own personal stories. March 23rd, I started a 2-week vigil on my mom's passing. We were in the long-term care facility with her. April 6th, she passed. April 18th, I took my dad to emergency room. April 23rd, he got out of the hospital, went to a rehab facility in a long-term care. Then he went to another long-term care facility. Of course, he had to be isolated in both those cases and in the hospital. Now he's out of isolation, but at a long-term care facility that's really locked down. And they're doing, knock on wood, everything right. You hate to tell these stories because you don't, you fear that the bad news will come. And so in my district, we've had 2,256 cases, 125 deaths, 55 have been in long-term care facilities. We've conducted 58,000 tests. So information is important. Talk about this long-term care issue. And I know some states have done other things, maybe not well, but in my father's case, he's been fortunate to be handled appropriately through the medical care folks in 3 different locations, actually 4. Can you talk about this issue on long-term care?
Well, first of all, let me say, Mr. Shimkus, my condolences for your loss and best of luck with your father. One thing I should mention is that, I mentioned the point about how 42% of all deaths nationwide have occurred in nursing homes, even though they're 0.6% of the population. Outside of New York State, it's actually over 50%. So in places like your district, in places like Illinois, it's over 50%. And there are some states, Minnesota, I think, is at 80%. I think in my written testimony, I have some of those maps in there that go state by state. So the problem is especially severe in certain parts of the country. And policy has had an impact on that. We've talked about, and I know you all are aware of how some states like New York, New Jersey, Michigan forced nursing homes to accept patients who had active COVID infections, even though those nursing homes did not have the wherewithal to quarantine those patients effectively. Other states went the other direction. Florida did a good job of locking down nursing homes. And, you know, what they'll tell you, it was very hard to tell loved ones, family members that they couldn't visit their relatives in nursing homes. That was not something that was a politically or morally easy decision to take, but they did it because they took the threat seriously. And I think now that we've learned more and more about this problem, when I started talking about this two months ago.
Dr. Roy, let me go to Dr. Brooks real quick. My
Sure.
time's running out. So Dr. Brooks, we're all big fans of FQHCs and community health centers, and I have stats from my local one and how they meet the needs of the Medicaid, the minority, Hispanic. They also have Spanish speaking attendance for those who need English as a second language. And I didn't want to go through all the stats, but the FQHC survived based upon benefits. And I think you raise a good issue. 3 to 5 year extension would be a helpful thing. That's the things that we need to hear as far as other opportunities. I know my community health clinics, I had a conference call with them a week or two ago, and they were addressing their response. They were very thankful for the $2 billion to help the FQHCs. Were you able to take advantage of that additional money for your community health center?
Yes, we were. We got $454,000 for testing, $67,000 just given, and then $927 in the CARES Act. So we did get some support, and we are actually appreciative of it.
And I thank you for that. And there's always more to do. We appreciate your testimonies. This has been a great hearing, Madam Chairman. I appreciate this time. Sorry about because it took me 25 seconds to get on. I will yield back my time.
All right, the gentleman yields back. Pleasure to recognize the gentlewoman from Florida, Ms. Castor, for your 5 minutes. And please unmute.
Yeah, thank you. Thank you, Chairwoman Eschew, for holding this important hearing on health disparities. The COVID pandemic certainly has highlighted the unfortunate health disparities across America. A recent press analysis here in Florida of Florida Department of Health data showed that coronavirus is twice as high among our Black and Latino neighbors here in this state, and now we're seeing an uptick in positive cases in Florida. So we're very concerned about this. And the fact that we really do not have modern data reporting systems. So Dr. Brooks, thank you very much for encouraging us to provide greater leadership on the standardization of data. I'm especially sensitive to this because there's been a troubling pattern in my state about data reporting and transparency. For example, the state previously withheld important data regarding nursing home infections and deaths. They had withheld certain data reported by our medical examiners. That is public record in Florida. And they also fired a data scientist. And she said they did that largely because she was asked to censor certain data. And, you know, we need this. Public health experts need this information so that we know that it's safe to go back to work, to go to school, to go out in public, and where to target resources. Chairman Pallone, I want to thank you very much for pressing the CMS Administrator, Seema Verma. She had said she would report the Medicare code data in March, and here we are in the middle of June, and we still don't have it. And I bet Dr. Brooks and Dr. Boyd can share with us why the Medicare coding data is so important and how that kind of data can improve the analysis on COVID-19 by race and ethnicity. So I want to turn it over to them and ask them to weigh in on that.
So I'll speak first. So yes, that would be extremely helpful. We're in the 21st century in the United States, and technology and data is what drives our decisions. So if you don't have that, you cannot make wise decisions. Those 65 years and older, those are the ones that are dying the most get hospitalized, and most in those are on Medicare. So if we have that data coming in, we can make calculated decisions on how to employ testing, how to employ healthcare services, how to employ public health messaging. So without that data, we're somewhat flying blind.
I'll
Dr.
add that.
Boyd.
Oh yeah, thank
Go
you.
ahead.
I'll add that in addition to Medicare populations, as a pediatrician, it's also incredibly important that we're capturing the emergence of COVID among our younger civilians. And I think all insurers should be collecting this data so that we can have it in real time, because the data lags affect how well we can respond to it.
So, Dr. Brooks, I've heard from a lot of my local public health experts and practicing physicians. They say reporting to CDC is completely antiquated. Sometimes they are still accepting facts, information from various sources. I mean, these come from multiple sources, from counties and health departments and states and hospitals, but this seems to be really outdated. What kind of advice do you have for us? And I know Mr. Walden asked you about reporting from your lab or from your office, and you may want to talk about or clarify what you're reporting and what your local health departments are reporting.
So now all our data is captured, including race and ethnic data on testing. Also on our ICD-10 or our coding that we submit, we call it encounter reporting. But the broader question is what you're raising. There needs to be national standards for data collection and reporting, and a national clearinghouse that manages this. And it's like you spend money on administration, but that's where there needs to be some money spent. And there needs to be a laser focus on this. It's really not that difficult in the computer age. The data's in there. So it's a matter of demanding it, collecting it, analyzing it, and acting upon it.
Great, thank you very much. I yield back.
Gentlewoman yields back. Again, the gentleman from Kentucky, Mr. McCray.
Thank you, Madam Chair. I appreciate you holding this hearing and how much we're all coming together to try to address this issue. And I'm glad we're here today to better understand these issues. But I want to specifically talk briefly about the Medicaid population. They're some of the most vulnerable, and the data on this population is less than optimal. The lack of data is evident in a CMS report published in November titled Quantifying the Distribution and Completeness of Select Demographic Variables in 2016. And I know we're going to do this at the end, but I take action at the end, but I like to submit this for the record. And the report finds that most states don't have race or ethnicity data for more than 10% of their population. And this is vital information for fighting the coronavirus and other diseases. And before I get to my question, I'll just mention about our colleague, if I can get through this, and dear friend of mine and a fellow Kentuckian. Yesterday, Andy Barr lost his wife, Carol. And it just reminds me, as we talk about all these statistics and numbers, and they're important, as Dr. Brooks said, you have to understand them or you're going to make the wrong policy decisions. But everybody that we're talking about is a life. It's a tragedy. It's a family. It's just people affected. And that's why it's so important that we address this and get this right. I was talking with Andy or communicating with him mid-afternoon yesterday, had no idea anything was wrong at all. And we still don't know exactly what happened, but she seemed to be healthy this time yesterday. And it's just tragic. But so we need to understand the numbers, but also understand the faces behind the numbers is just what I want to share. But with Dr. Roy, I would ask you, and the others could comment as well. I guess I've used up a couple of my minutes already, but you mentioned in your testimony that more data is needed, and I think everybody's talked about more data is needed. And I guess getting back to the personal side of it and addressing the issues, once we have data, how quickly or how fast do you think, Dr. Roy and the others, we can pivot to address these disparities?
Well, Mr. Guthrie, I'd say that there are certain aspects of it that we can address very quickly in the sense of, for example, the nursing home piece. There's a lot that states and localities and the federal government, Congress can do today to address the nursing home disparities. Then I would talk about Medicaid. You mentioned Medicaid. There are a lot of challenges with Medicaid, both in terms of the way Medicaid steers people into nursing homes instead of facilitating them getting the care they need in their own homes. And also just the fact that Medicaid, because it pays so little to providers, particularly primary care physicians, that people enrolled in Medicaid don't get access to primary care, therefore have poor management of chronic diseases, which, as we've seen in COVID, is lethal. Those are two things I would talk about in terms of things that, short-term, midterm, and then obviously the issues related to the legacy of slavery and segregation, structural racism. These are big challenges that we obviously need to put a lot of attention into, and I welcome all members of Congress doing so.
And Dr. Brooks, and then Dr. Boyd, if you'd like to comment. I have a couple of minutes left.
I'm sorry, I had to unmute myself. I think that one thing is the focus on right now, implicit bias training. We are all talking about racism, something that can be right now. There's studies that show that when police officers, healthcare providers have implicit bias training, they make better decisions, better informed decisions. And, we did talk about this once, but the digital divide. If allow more access to broadband, we know right now that would have a positive effect, just in terms of access to information beyond telehealth. So those are two acts that I would say I would do immediately beyond any other data that may come subsequently.
Thank you. And Dr. Boyd?
I would also say we have an enormous amount of data already that we can start acting on. Part of that data is that 8 out of 10 of the COVID clusters have actually been in correctional facilities. In addition to thinking about nursing homes, we have to think about all congregate living sites, homeless shelters, correctional facilities, detention facilities, and what we're doing to focus on those populations. So I would call us to act on the data we already have that is alarming, that multiple people have noted.
Okay, thank you. And then I'm also on Education and Labor Committee. We had a hearing on the length of the summer and summer learning loss. And a lot of it came up, particularly there was the superintendent of the Cleveland schools. And just even though that's a big city and has broadband, just the access to the devices and just the disparity of families that have higher incomes and lower incomes, and just in terms of access to broadband. And that doesn't just affect health, it affects education. So I appreciate you all being here, and this is important. And thank you, Chair, for bringing this hearing together, and I yield back.
The gentleman yields back. The chair now recognizes the gentleman from Maryland, Mr. Sarbanes, for 5 minutes of questions, and please unmute.
Thank you, Madam Chair. Can you hear me?
I can, very well, thank you.
Appreciate this this hearing. I want to thank the witnesses who joined us today. This is an extremely important topic. Maryland, like the rest of the country, is suffering, and communities of color in Maryland have been particularly hard hit by the coronavirus pandemic. There's lots of different reasons for this, and our witnesses today have discussed those. But among them certainly are the longstanding issues of inequality and racism that we experience in our country. In my state, African Americans are now accounting for 29% of the population, but 41% of the coronavirus deaths. Hispanic or Latinx individuals are 10% of the population, but represent 33% of the diagnosed coronavirus cases. So these numbers obviously are unacceptable. We're working hard in this committee and in Congress to address the root causes. I would like to have submitted, I know at the end of the hearing you will be accepting a unanimous consent request from members to submit things for the record, but our Attorney General, Brian Frosch, authored an article today which discusses the health disparities, the disproportionate impact. It's an excellent overview of what the experience in Maryland has been, and so we have submitted that for the record. Dr. Boyd and Dr. Brooks, thank you for your testimony. I'd like to merge together two topics that have already been alluded to in earlier discussion today. One has to do with distribution of vaccine, if we can ultimately get the vaccine into communities that have been disproportionately impacted, and the other has to do with sort of culturally sensitive and competent workforce, and how we deliver treatments, vaccines, and other things in various communities. If you could speak again to how critical it is, and maybe let's use the availability of a vaccine as the way of doing this, how critical it is to make sure that the delivery of a vaccine is done in an equitable fashion, and how important in accomplishing that is that we have a healthcare workforce that has a sense of understanding and connection to the communities that we're trying to reach, because I know those are issues that both of you put front and center in the work that you do. So why don't we start with Dr. Brooks and then go to Dr. Boyd.
So the equitable distribution of the vaccine is critical, and it may not be as easy as it sounds. Should you give it to those in long-term care facilities? Should you give it to first responders? Should you give it to doctors on the front line? Should you give it to an 80-year-old Black man with diabetes and hypertension? So it'll also be the amount of vaccine that we can produce per month. That being stated, I do know that work is ongoing, and I am very happy with the way that the decisions are being made thus far. As it relates to in the communities, yeah, the issue with police and police brutality, there are issues with race, and it would be better if we had more representation, like community advisory boards and other actions that address implicit bias and racism in police, and that flows over to the vaccines.
Dr. Boyd, could you speak to what it means to do outreach in certain communities, and what it means to have that cultural sensitivity, particularly when it comes to delivering healthcare opportunities?
Yes, I think we've already seen as a pediatrician that we've had lower rates of vaccination because of how COVID-19 disrupted preventative care, primary care access for patients. And so as we, as a healthcare system, flex to go to telehealth and outdoor clinic settings, I think we also have to think about accessible platforms for patients to get the vaccine, even for kids to get their regularly scheduled vaccines, and definitely for families and communities to get the COVID-19 vaccine. Having platforms that are available in folks' communities that they can walk up to and not have to have a car to drive into, I think would go a long way in making sure that access is more equitable.
Thank you very much. I yield back.
Gentleman yields back. A pleasure to recognize the gentleman from Virginia, Mr. Griffith, for his 5 minutes. Are you unmuted?
I believe I am. Can
Yes,
you hear me,
you
ma'am?
are.
Thank you, Madam Chairman. I appreciate that. Dr. Brooks, you brought up in your testimony and some of your comments that hypertension and diabetes are a concern. I thought that was interesting because I was reading an article over the weekend that talked about how the deserts, particularly in poor communities, in African-American communities, et cetera, lead the folks in those communities to be overweight, thus more hypertension and diabetes. Do you think that that's something we should look at as a part of all of this that we're looking at?
Absolutely. That's one of the primary social determinants of health that is leading to adverse outcomes. African Americans are more likely to be food insecure, 22% versus 12%. And you all know that it's hard to get to the market. We're doing this now. So even under COVID, if you don't have that access, it's going to even be worse. So actions that reduce food insecurity will directly lead to better health outcomes.
Well, and correct me if I'm wrong on this, part of what I interpreted from that article was that there may be some, like a corner store or something, but they're carrying potato chips, frozen pizzas, Vienna sausages, et cetera, all things that are high in sodium and which are not particularly healthy. And because there's not a full service grocery store, even though they might be able to get some food, they're not getting the healthy foods that would help them with their weight issues, hypertension, or diabetes. Is that also fair?
That is true, and that is part of what directly informs the statistics of food insecurity. So access to healthy foods and the ability to purchase it are what define food insecurity.
appreciate that. I also appreciate you bringing up telehealth. I represent a very rural community where telehealth is also important. It's one of those things I'm now curious if there would be a study, because the most rural parts of my district also have higher levels of hypertension and diabetes as well, even though it's not a minority population. It is a poor population that is separated from easy access to full service grocery stores. So that's an interesting point. And telehealth is going to be huge. We've got to get the broadband out there, whether it be through white spaces, whether it be through low orbit satellite, or whether it be through laying of fiber. But I appreciate that. Dr. Roy, I'm going to switch gears completely and go with you about something that you were talking about, nursing homes. And we know that the older populations and the nursing homes have been, particularly because of the congregate care, subject to both getting the disease and then obviously because of the comorbidities, those mortalities. I had a concept that was brought to me a number of years ago when I was in the state legislature. We actually got a law passed in Virginia to allow a zoning variance for this, and then North Carolina followed suit. And you would basically create a medical cottage, which then could be placed into somebody's backyard, so that if I wanted to put my mother-in-law out there in the backyard because she had some issues and there were requirements that you have two needs for daily medical help, but that if I want to do that, I could then have her in the backyard instead of putting her in a nursing home. The concept has never taken off because Medicare and Medicaid don't reimburse that at all. And obviously, you know, unless you're extremely wealthy, you can't afford to rent a medical cottage and stick it in the back yard. But the data that we looked at when we were developing this, the data indicated it would actually be cheaper than nursing homes and you would still be closer to family. Do you think that's something that this might be the time might have come for us to push Medicaid and Medicare to reimburse something like this, so that not only would people be closer to their family, but they also wouldn't be in congregate care settings where they're more susceptible to getting a virus like this?
Well, Mr. Griffith, what I'd say is that in the non-public programs, among people who can afford to do it, home-based care is exploding. So overall, it's a trend that we're seeing. It's just that Medicare and Medicaid were designed at a time when none of these things were part of the thought process or equation. So absolutely, we need to update and upgrade Medicaid and give states the flexibility to do more, to pay for care in a home-based setting. Right now, Medicaid, basically, as you said, because of the way it reimburses Medicare to also, but it's particularly a Medicaid problem. It really steers people to these congregate facilities. So that's very, very important. More people should be taken care of at home. It's less expensive and it's also safer. And then we're going to have to really do a much better job of overseeing the way, oversight of nursing homes. There's in theory all sorts of oversight in place, and for whatever reason, it just doesn't seem to ever work. And so nursing homes don't have the ability to do adequate infection control. There are lots of GAO reports and others about this problem.
Well, I appreciate that, and we'll be looking into that more and may contact you. And I don't know how much time I have, if any, but I'm happy to hear from either of the other witnesses on that concept of having.
I think the time has expired, Mr. Griffith.
Well, then I yield back. Thank you, Madam Chair.
Okay, thank you. The gentleman yields back. Pleasure to recognize the gentleman from New Mexico, Mr. Lujan, for your 5 minutes of questions. And unmute, please.
Thank you, Madam Chair. Great to be with you. And thank you to each of our witnesses for joining us today. The coronavirus pandemic has exacerbated many of the longstanding health disparities in our country. In my home state of New Mexico, some rural and tribal communities don't even have access to running water, to wash their hands, to bathe, to cook, to drink, which we know is essential to preventing the spread of the virus, let alone broadband for a telehealth visit for their doctor. Dr. Boyd, these are exactly the types of COVID-19 protections and COVID-19 supports that you describe in your testimony as being inequitably distributed, correct?
Yes, in our country, instead of income, racial group is the strongest predictor of access to clean water, and Native Americans are 19 times more likely to lack access to clean water in their homes than white households. So yes, absolutely.
So Dr. Boyd, how has the inequitable distribution of COVID-19 protections and supports impacted the spread of the virus?
So just speaking of clean water, if you don't have access to clean water, and hand washing is one of the primary ways that we limit the spread of infectious disease in this country, it then affects your ability to keep yourself safe, your kids safe, your family safe. So if we know that clean water access is determined by a racial and ethnic group in this country, that means that we're limiting the protections we provide communities by their racial and ethnic group, and that's what's unjust.
I mean, you said it best, Doctor. The results have been devastating. And for example, 9,845 COVID-19 cases in New Mexico, nearly 58% have been Native American. The Navajo Nation has more cases per capita than any other state in the nation. This wasn't inevitable, though. It was caused by systemic inequities in our healthcare system and in our society. And, well, I know this may be hard for some of my colleagues to say today. The Trump administration's failed response to this crisis. The Indian Health Service, which has been chronically underfunded long before this pandemic, faced long delays in receiving requested testing supplies for the Navajo area and Albuquerque IHS hospitals. When I called the White House to push for the delivery of these supplies, the administration could not give me a straight answer as to whether it was going to deliver these supplies or how it was going to meet the needs of the Navajo Nation and the Pueblos. The Trump administration also awarded a $3 million IHS contract to an 11-day-old company run by a former White House staffer, which delivered thousands of substandard masks that were unfit for use. Then we learned the CDC is not sharing critical data with tribal epidemiology centers the way they share it with state health departments. Tribes need this data to protect their communities, and they're entitled to access it as sovereign entities. And just this last week, the state of New Mexico is investigating allegations that a private hospital racially profiled Native American mothers and separated them from their newborn infants during the first crucial days while awaiting COVID-19 test results. If it's true, it's horrific and completely unacceptable. So, Dr. Brooks, can you speak to how instances like those I just described contribute to mistrust of the healthcare system in many minority communities and some of the history behind that?
So what you described does not sound too different from what happens in the African American community. As a pediatrician, I do understand the critical nature of that bonding of the first 4 hours after the baby is born. So that separation was untenable and is not being done anywhere else. So I almost want to say Native American lives matter and to add that to the list. It just speaks to systemic inequities. And what concerns me is that, the inequities have been going on in Native American populations, say 200 years, African American populations, 400 years. It's the same. Whereas, what do we do now? So it's hard to reverse 200 to 400 years of inequity. I think the main thing is what you did. I would call the I'm not you, but I would call the White House again, and you probably did. I've been telling my patients and my people to stomp your feet. In other words, just get active and stay active. Don't take no for an answer. It may be easy for me to say because you're talking to the White House and not getting responses, but that's the best I can say. I feel for you and those that you represent.
And then Dr. Brooks, as my time concludes here, can you just elaborate on why diversity in clinical trials is so important, both in ensuring equitable access to the latest treatments, but also in ensuring that researchers have all the data they need to demonstrate that new treatments are effective for all patients?
So, yes, what you just said, make sure the treatments are effective, but also I think it's the general concept of these people matter. We need to include African Americans, Native Americans, Pacific Islanders, because we're thinking about them. They are on our radar. We're not just because we're made to do it.
Thank you, Madam Chair, and I yield back, and I'll also be submitting some information into the record at the end of the hearing. Thank you.
The gentleman yields back. Is Mr. Bilirakis prepared to question? I don't see him or hear him. I did before. Let's move to...
Here. I'm here.
Oh, there you are. And you're unmuted, so you can begin your question. And so pleasure to recognize you.
Yeah, I was concerned about my hair, but then when I saw Fred's hair, I said,
Oh, you look great. You look
I'm
great.
okay. Yeah,
Not to
yeah.
worry.
All right. Dr. Brooks, approximately 36% of African American Floridians experience obesity, the highest percentage of any racial or ethnic group in the state, and 31% of the Hispanics experience obesity compared with 27% of the Caucasians. As of June 8th, 2020, 27% of COVID-19 hospitalizations and 21% of deaths statewide were among African Americans. Only 17% of the population of Florida is African American. According to a June 3rd, 2020 analysis conducted by the CDC, Hispanic Floridians make up 46.5% of the COVID-19 deaths when weighted population distributions are considered, reflecting a disproportionate burden of COVID-19 mortality, unfortunately. While Congress and the administration have taken actions to increase access to telehealth, enhance state flexibility under Medicaid, and appropriate hundreds of billions of dollars to combat the COVID-19 pandemic, what can be done to ensure that seniors have prompt access to treatments for obesity once they are approved by the FDA?
So obesity does directly lead to diabetes. Diabetes is diet, exercise, and healthcare. So diet, if you're food insecure, you're not going to eat well. If you live in a crowded house, you're not going to exercise as much. And if you don't have insurance, you won't get the medical care. So we really need to look at those underlying conditions. The treatment for diabetes is actually lifestyle more so than anything else. As it relates to medications, like for example, metformin, glyburide, insulins, you're more likely to get medical treatment if you have health insurance. So I'd say Medicaid expansion, universal health care. These are the actions that would drive decrease in diabetes and therefore decrease in adverse outcomes.
Okay. Now, there are medications also in the market to treat obesity specifically.
Okay.
I know about metformin as well. But what are the effects of those medications? Have they been successful? I'm also concerned about any adverse effects of those medications. Can you elaborate quickly on that, please?
So yes, there are some medications that treat obesity, diet suppressors, but in general, those haven't been that successful. The main treatment for obesity at this point, other than managing with diet, is the surgery, fundoplication or gastric bypass surgeries. So better access to that surgery by Medicaid would actually help quite a bit.
Does that include, are those surgeries included reimbursement under Medicaid or Medicare? I know private insurance takes them.
So, and at least in California, yes, if you meet specific criteria, yes.
Okay, thank you. Next question is for Mr. Roy. Do stay-at-home orders disproportionately impact racial and ethnic minority communities? And if so, how?
Well, thank you for the question, because we've been talking a lot about health outcomes and they're very important, but we have not been talking enough about the economic disparities that have been created by the lockdowns, which is an incredibly important problem that affects tens of millions of Americans. Yes, so as I mentioned in my oral testimony, it's also in my written testimony, because non-whites are more likely to be hourly wage earners or in other jobs or occupations that require physical presence. They can't work from home. They can't Zoom all day to do their jobs. They're both more at risk if they're in a high risk occupation from COVID, and they're also more at risk of facing unemployment. So this has been a huge problem, particularly in the lockdowns. And we've talked a lot about nursing homes today. The flip side of the fact that half the deaths are happening in nursing homes outside of New York State is that younger Americans in general are at lower risk. That both affects schools. You know, we've had these school closures, which have huge economic consequences, not only for the children, but for the parents, particularly single parents who can't go to work because going to work means leaving their children unattended at home. And also the people who've lost their jobs due to the economic lockdown. So there are a lot of problems when it comes to disparities on the lockdowns. And I think we need to do a lot more to refine and target our economic restrictions to the populations who are most at risk.
Thank you. I appreciate that. Dr. Brooks, recently...
I think the gentleman's time is expired.
Okay. All right, I'll submit it for the record. Thank you very much, madam.
All right, thank you, Mr. Bilirakis. Next up is the gentleman from Oregon, Mr. Schrader. Are you there? If not, then we will go to Mr. Kennedy of Massachusetts.
I would just go to Kelly since she's next and she's on camera.
All right, then we'll go to the gentlewoman from Illinois, Ms. Kelly.
Oh, I didn't think I was going to come up that quick.
Well, there are members missing in action here.
Thank you so much, Madam Chair, for having this. You know, this is something near and dear to my heart as chair of the Congressional Black Caucus Health Brain Trust. We have been working so hard around this issue, but not just around COVID, around maternal mortality and other issues also. So I just want to thank the witnesses for their comments, because if we don't do anything about the social determinants of health, we're going to revisit this, you know, with other illnesses over and over and over. And also, you know, the statement that it's racism, not race, is so true. I lost my uncle to COVID, so I appreciate my colleagues saying that it's not just statistics. We know real life people, and he worked all his life. He lived a good life. He wasn't poor, but he lost his life off. The church he had 60 steady people that went to the church. 16 of the 60 people are now dead because of COVID in New Jersey. So we've been in Chicago, not now, but 72% of the people that died were African American, and I think we're 29% of the population. So I mean, we've just seen it all around. Things have improved, but if you could, all of you can just answer if there's, because we can have hearings and we can do all this, but if we don't implement anything, if we don't do anything, then, you know, the hearing is in vain. So if each of you could just one thing that we have to do in leaving this hearing, what would it be?
All right, this is Dr. Brooks, and I will speak first. First, I want to just pause and thank Representative Robin Kelly for all she has done for the NMA in supporting us, including gun violence, which is not a discussion today, but she's been there, and we thank you. If I would say one thing, I would go to implicit bias training, because I do believe that the racism that occurs, a lot of it is subconscious. Some is conscious. We have 2 people that were hung in California. That scares me right now, quite frankly. But when you have implicit bias training, it makes you, first of all, let's say as a white person, think about it. And then second of all, it makes you do something about it. And so that racism that is inherent in our society needs to be addressed. So that would be my method of addressing it.
And just real quickly, we spoke to a Black doctor who gave an example that he had a tennis elbow, and he went to the doctor, and the doctor was white, but he didn't tell the doctor he was a doctor, and all the things the doctor said that he should do. And then he would say, well, shouldn't you be doing this, or shouldn't you be doing that? And the doctor eventually said, oh, you must know something about healthcare. After he told him he was a doctor, that's when he said, oh, okay, let's do this, or let's run this test. You know, so Dr.
Yes, I would also like to begin by just saying I'm so sorry for you and your family's loss. It's so devastating. I think if there was anything we were really going to push other than universal health care, it's to end segregation. Studies have shown that if you end residential segregation, you will close the black-white gap in income and unemployment and education. And those are powerful social determinants of health that are shaping our COVID inequities that we've seen. So ending residential segregation has to be a priority.
And we see that in Chicago, a 9-mile difference between the south side and I believe the west side. My colleague, Bobby Brush, can correct me, and the people that live north, 9 miles difference, a 30-year difference in lifespan. So, Mr. Roy.
Yes, well, building on what Dr. Boyd said, educational attainment is the most important social determinant of health in terms of its correlation to health outcomes, and that's obviously driven a lot by residential segregation. The other thing I would mention is we've talked a lot about Medicaid. Medicaid reform, particularly Medicaid reforms that increase access to primary care for management of chronic diseases, and also getting people out of congregate facilities and into more home-based care. Those are extremely important things that Congress could address today if it wanted to.
Thank you all for what you do, and thank you for being witnesses today. Really appreciate you. And I yield back early.
The gentlewoman yields back. The chair is now recognized, the gentleman from Indiana, Dr. Bouchon.
Thank you, Madam Chairwoman. I'm just restarting my own clock here. As you may or may not know, I was a cardiothoracic surgeon before coming to Congress. And as I look at the available medical data being reported on COVID-19, it is clear this virus has disproportionately affected racial and ethnic minority communities, in particular our nation's Black communities. Although, as we have heard, more accurate data is needed. There are still many questions as to why this is the case and what all factors contribute to it, but I'm deeply troubled by reports that show it's not necessarily the infection rate that's disproportionate, but rather the mortality rate for minority patients that become infected with the virus, which is so strikingly disproportionate. This is happening to communities all over America in urban settings and in rural settings alike. Through my medical practice, I understand that there are real racial health care access disparities that exist. And in certain underlying health conditions such as diabetes, hypertension, and heart disease, the prevalence is greater in some of our minority populations. This committee has recently dedicated work to addressing racial and ethnic health disparities in maternal mortality. It has been eye-opening yet informative to hear from hospitals across the country on steps they are taking to improve in this area. It helps showcase how no one urban or rural setting is the same. In fact, we heard from Parkland Hospital in urban Dallas who shared impressive stories on how they're improving maternal mortality in their community. Their data is impressive. This can be done. As for COVID-19, I think there are similarities, and I have tried to focus my efforts on providing access to quality care, a suggestion each of you had in your testimonies. This is why I recently teamed up with Representative Diana DeGette to introduce 2 bills which would increase diagnostic testing capabilities of public health laboratories and expand testing access to hospitals, physicians, and other health service providers. HR 7025 and 7026 both prioritize underserved populations to help provide better access to those disproportionately affected by public health emergencies such as COVID-19. Dr. Roy, as my colleagues and I work to build up our nation's testing capabilities so that Americans can better access these tests, what can be done simultaneously to help ensure individuals actually go receive these services once access is there? This is particularly important because a concern of mine relates to future vaccines for COVID-19 once it is developed.
Well, Dr. Bouchon, I would mention the geographic location of the tests is really important. My family, my wife and I had to get tested for COVID-19 recently due to a possible exposure. We had to drive 35 minutes from our house to get to a place and then sit there for several hours to get the test. Now, some people don't have the luxury of doing that because of their jobs or other situations. So making sure that the test availability is close to your house and very rapidly accessible is really important. Obviously, that's been a challenge.
Yeah, it has been a challenge, and transportation issues are obviously a challenge in different communities. But we want to get out ahead of this as we look forward to having a vaccine. In that vein, Dr. Brooks, is there a disparity in vaccination rates in general between ethnic groups?
Yes, there is. African Americans are lower, more or less likely to be vaccinated, both at the NIS National Kindergarten Survey that is done on a yearly basis, and then in vaccine for influenza. Some of this is directly related to access. If you are less likely to be insured, you're not going to get vaccinated. So when we come forward with a vaccine against COVID-19, that has to be kept in mind. And I think imperative will be the messaging. The message has to be culturally sensitive, come from messengers that the African American community can identify with, and again, have African Americans involved in the clinical trials so we can speak to the safety and efficacy for African Americans.
Well, you answered my second question, which is going to be how do we avoid disparities? And because cost probably will not be the issue, because I think the Congress will make sure that people will have access to free vaccines for something as critical as COVID-19. But I appreciate you answering that question. And since we know this may be an issue, I think we all need to work towards making sure that when we actually have a vaccine, the historical problems that we have getting access to vaccinations for minority communities don't apply to COVID. Thank you very much. And Madam Chairwoman, I yield back.
Yields back. The chair now recognizes the gentleman from Massachusetts, Mr. Kennedy. For his 5 minutes. Are you unmuted?
I believe so. Can you hear me?
Yes. Good.
Great. Madam Chair, thank you. Thank you for calling this extremely important hearing. Thank you to our witnesses for being here and for your work and your dedication to this. Massachusetts has been hit extremely hard by this virus. We've had over 100,000 people infected and over 7,500 deaths. One of the most memorable moments for me will be spending some time in Chelsea, a community just east and slightly north of Boston, that has a rate of infection about 6 times higher than the state average. It is largely immigrant, largely working class, largely Hispanic, disproportionate percentage of essential workers. And I was a Peace Corps volunteer. I served in the Dominican Republic for about 2.5 years, and I've visited or done work in development in many countries around the world. I have never seen lines so long for food in my entire life than I did in Chelsea, Massachusetts. I spoke to the head of one of the community health centers that operates in the neighborhood, and I asked him how they were doing, and he said that they had just received new mapping software. This was about a month ago, and that they were looking for cool spots with infection. And I asked him, I said, well, why cool spots? Don't you want to mitigate against hot spots? And he said, no, we know everybody's infected. Everybody's been exposed. We need to see where we haven't tested. And the biggest cool spot on that map was the affordable housing development, where out of the 900 residents there, only 4 had been tested. So when we talk about these infection rates, they're also a reflection of access to testing that are in and of itself subject to these disparities and structural inequities that we've been talking about today. And so let me be clear about this. We have not only failed lower income and Black and brown communities with regards to this virus, we failed them long before anybody uttered the word coronavirus or COVID-19 or knew what social distancing was. We failed them in a million ways that extend far beyond whether the president took this pandemic seriously or whether we thought it was going to impact his political survival. We failed because our government had dismissed workers' rights and living wages for people across our entire country. We have failed members of our community over and over again. We've underfunded education and healthcare and food insecurity in communities of color. We have failed by not letting our public transit options crumble and our public housing deteriorate. And right now, we cannot fail them again. So I think back to those lines for food in Chelsea, and I can't help but think of what might happen when we do have an eventual vaccine. If we're going to be sure that history does not repeat itself, which it will if we do not act, wealthier and white communities won't see those shortages or long waits, but others certainly will. And so with that, I want to start with Dr. Boyd. What policy should we be enacting now to ensure that those communities that have been hardest hit and least prepared are going to be able to receive access to that vaccine?
Thank you, Congressman Kennedy. I think we should prioritize those communities alongside other groups we determine are high risk. For example, if healthcare workers are the first to receive the vaccine because they're most high risk for exposure, only 5% of physicians in this country are African American. So we have to ensure that the communities that are affected are also prioritized alongside healthcare workers and other high prioritized groups.
Dr. Brooks?
I believe that messaging, again, getting the word out there that there is a vaccine, that it is safe and effective. I do also believe that healthcare workers should be prioritized, but also understand that African Americans that are elderly and with underlying conditions are at highest risk for death. So there should be clear messaging to that population.
And at the beginning of this pandemic, we focus on attention on elderly and those with pre-existing conditions as parts of a high-risk population. Dr. Boyd, starting with you, I understand there's been some recent research that has also come out about age being a driver in these disparities. Can you talk to me a little bit about that?
Absolutely. So a study was just released from Harvard School of Public Health that looked at age-specific mortality rates. And actually among African Americans, those aged 35 to 44 have the largest gap. They are 9 times more likely to die of COVID-19 than white Americans. They also calculated the years of life lost, and more than 45,000 years of life had been lost per 100,000 African Americans. That's more than the 33,000 years of life lost for white Americans, despite white Americans having a larger population. So how we talk about age actually has to change. Younger communities of color are more affected.
Do you know, walk me through the reasons, the rationale for that? I mean, what we've heard over and over and over again is obviously the virus. The statistics seem to show that it's far more deadly for older people, but the impact that you just articulated. Over time, so forgive me, but maybe I'll ask you about that or to flesh that out when you can. And I apologize, but I do have to yield back.
Can you, Dr. Boyd, can you answer that in 30 seconds?
Yes, one mechanism that we have to consider is allostatic load and weathering, that experiences of discrimination and racism actually age cells faster. And so although your chronological age may be younger, your cells may actually be sicker and older if you've experienced cumulative exposures to racism and discrimination.
Thank you.
The gentleman yields back. It's a pleasure to recognize the gentlewoman from Indiana, the wonderful Congresswoman Brooks. Are you unmuted?
Yes, can you hear me?
We can see you.
Good to see you and good to see everyone. Thank you to all of the doctors for your really important testimony. Something that we haven't talked about yet are the importance of using electronic health information exchanges and all of the data, and all of you are so involved in the data collection and understanding it. We have in Indiana called the Regan Streif Institute celebrating its 50th year, and it is all about modeling and information sharing and data collection. And they've partnered with IU Health here in Indiana, and they just did a study that talked about the quality of healthcare data varies greatly based on how user-friendly the collection system is. And that seems like something just so very basic, but they found that still many people on all of this data submit it by fax. And I'm curious, in this modern age where we are all communicating through WebEx and so forth, can each of you comment what you know on current data collection standards for COVID-19 and what maybe suggestions you might have for Congress for standardizing data collection? Because, and not that I am necessarily questioning this data, but I don't think we're getting all of the data in the most accurate way we can and should be getting it. So maybe Dr. Roy, I'd love to hear from each of you about this whole issue about the manner in which data is collected. Maybe start with you, Dr. Roy.
Yeah, so Ms. Brooks, the first thing to talk about is the HITECH Act, which was passed as part of the stimulus legislation in 2009 that transformed a lot of the mandates around the way electronic health records must be taken and transmitted. So that's the governing statute right now, is the HITECH Act, which has been, I think, tweaked and modified here and there. The one thing I would say on top of whatever you want to do in terms of thinking about how the HITECH Act governs these processes is that there is actually a lot of technological innovation going on in electronic health records. To give one example, you're starting to see people use voice recognition software in a physician's office to artificially use artificial intelligence to record a patient encounter and thereby streamline some of the generation of patient notes. That plus lab data can be more seamlessly integrated. Part of the problem is anti-kickback statutes and HIPAA and other privacy laws that basically restrict the data liquidity. So it's very hard for your primary care physician and a hospital and your endocrinologist and your cardiologist to communicate with each other about your situation as a patient because of all these privacy restrictions. And obviously privacy restrictions are important to a degree, but we need to modernize those laws. The Trump administration has put out some proposed recommendation rules and changes, final rules to modernize the regulations at least. But I think you need statutory modifications as well to streamline and modernize these old, outdated statutes so that patient data can bounce back and forth between providers and patients.
Thank you. Dr. Brooks, does your association talk about the whole data collection challenges and your concern about the data?
Yes, we do. I would focus first on what your statement regarding health information exchanges. We are almost there, but there's the devil in the details. Dr. Roy mentioned the HIPAA concerns. There are no, to my knowledge, clear standards of COVID-19 data collection, and there needs to be. And I would even loop back to health information exchange in African Americans. African Americans are more likely to get fragmented care, get care in the ER, get care at a health center, than go to a county facility for a referral. So that data ends up getting lost. And so not having that data sharing does adversely affect African Americans. So it kind of all goes full circle.
Thank you very much. Dr. Boyd, do you have anything to add in my 30 seconds remaining?
I will also say biased data in leads to biased learning out. So if we also only collect this data for populations that already receive government-sponsored health insurance, for example, or our Medicaid populations, and not for all Americans, just regardless of your health insurance status, we also aren't learning about the full population level burden of infections and deaths.
Thank you. Thank you, Madam Chairwoman. Thank you all. I yield back.
The gentlewoman yields back. A pleasure to recognize the gentleman from California, Mr. Cardenas, for his 5 minutes of questions.
Thank you very much, Madam Chair, for giving me the floor, and thank you so much for having this important hearing. I don't know if you could see me, but I hope you can hear me.
It's both.
Okay, thank you.
Look great.
My screen just went blank, but it's working. Okay, thank you. As Dr. Brooks said in his testimony, and others have discussed, as a result of the coronavirus pandemic, a bright light has recently been shown on the health disparities and inequities that have always existed in the United States. There are several factors that experts have pointed out to explain these trends. For example, regardless of their profession, Black American, Latino, and Indigenous populations also have disproportionately less access to paid sick leave, garner the lowest median wages, and predominantly live in states that fail to mandate critical worker protections like paid sick leave and living wages. Black American, Latino, and Indigenous populations are also overrepresented among the homeless, the incarcerated and detained populations in the US, which confines people in crowded facilities that also dramatically increase risk for COVID-19 exposure. Accordingly, 8 of the 10 largest clusters of COVID-19 infection have occurred in correctional facilities, which, by the way, affects the people who work there, not just the incarcerated. While the number of uninsured individuals across all demographics increased following the Affordable Care Act's passage, Blacks, Latinos, American Indians, Alaska Natives, Native Hawaiians, Americans in our territories, or other Pacific Islands are also more likely to be uninsured compared to whites and more likely to report going without needed care due to cost. Studies also show that racial and ethnic minorities receive lower quality healthcare even when insurance status or severity of conditions are comparable. As we are the country with the most and best research and the largest economy in the world, what I report today and what we're hearing is shameful. We can and must do better. One area that needs more attention in is mental and behavioral health. Before the pandemic and the worldwide protests condemning the recent police murders of Black Americans, our mental health system was in bad shape. And now these events have made our collective stress levels skyrocket, and our mental and behavioral health continues to be disjointed and disconnected from any other type of healthcare. Experts are warning that a historic wave of mental health problems is approaching. Depression, substance use disorders, anxiety, post-traumatic stress disorder, suicide. Over the weekend, new reportings show that the rates of clinical depression have more than tripled since the coronavirus first emerged, and Black Americans have experienced a particularly high evidence of major depression disorder. We also know that racial and ethnic minority groups in the US are less likely to have access to mental health services, less likely to use community mental health services, and more likely to receive lower quality health care. In 2017, 42% of youth aged 12 to 17 received care for a major depressive episode, but only 35% of Black youth received services and 33% of Hispanic youth received treatment for their condition. Black individuals with mental health and substance use disorders are more likely to be incarcerated rather than placed in community-based diversion programs. What are some of the things we could do at the federal level and to advance health equity within the mental and behavioral health space? Also, what will be the consequences if we don't act to address racial and ethnic health disparities within the mental health space? Dr. Boyd, can you elaborate perhaps on what we could do?
Yes, particularly for youth, we know that mental health impairments are the #1 cause of school dropout rates. And kids who don't finish school have higher rates of entering the criminal justice system, as you mentioned. And so we have a healthcare to prison pipeline that we have to address. One way to address it is to broaden access to mental health supports. Many health insurances don't cover counseling, in-school supports, and other community-based programs that help kids address their mental health needs. We could do it for all ages, but I would also advocate starting with kids.
Thank you. And Dr. Brooks, if people are unable to get information and treatment in their language, and the CDC has only translated into 4 languages, when there are 200 languages spoken in America, is that going to adversely affect our ability to end this pandemic in America?
Yes, it will. You need information in your own language, and America is a multicultural society, and that's what makes us great. So more translation services and that would lead to more access, especially as it relates to mental health. So with better mental health, you get better physical health. So I think that's crucial also in terms of your point about being disjointed. You need integrated behavioral health services, which will lead to better physical health.
Thank you, Madam Chair. I yield back the balance of my time.
The gentleman yields back. It's now a pleasure to recognize the gentleman from Oklahoma, Mr. Mullen, for his 5 minutes of questions.
Madam Chair, can you hear me okay, or is my connection again?
Yes.
Okay. Well, thank you. And if my connection gets bad, please interrupt me so I'm not just talking to myself.
Okay.
While I'm very happy we are having these important discussions on health disparities, as you guys know, I'm Cherokee, Native American, and it's very disappointing to me that we don't have a tribal witness here today. I know when Chairman Burgess had brought this up to you, Madam Chair, that you had said we were going to possibly do a field hearing. Is that correct, on Native American issues?
I would very much like to do that, and I think that there's interest on the part of enough members in order to do that. And I also believe that we need to this should not be the only hearing we have on recent disparities of our subcommittee.
Yeah, Chairman Eshoo, or Chairwoman Eshoo, my concern is that with COVID going on, that a field hearing probably isn't going to be possible. And Native Americans are disproportionately left out on these studies, on things moving forward. And we see pockets breaking out in our reservations in parts of the Indian country. And so I just hope that you'll commit that the next one we have will have the tribal witness there. Hopefully someone that maybe you would even allow me to bring in as a witness, because I do have close ties with them, and it's a nonpartisan issue. This should be a bipartisan approach, because Native Americans, as you know, Madam Chair, IHS is greatly underfunded already, and then they're extremely stressed with the COVID crisis going on.
We will work with you, Mr. Mullen. Thank you.
Thank you. Dr. Brooks, I'd like to talk to you for a little bit. As I was stating, American Indians experience a disproportionately rate of individuals with diabetes. In fact, it's 3 times more likely if you're American Indian to have diabetes than any other race. And when you start talking about inside the United States, autism is also the highest in Indian country. Can you discuss how social determinants on over health can play roles in chronic conditions, not just with COVID, but other diseases out there too?
Yes, so thank you. So interesting, you mentioned autism. There is some early data showing that environmental exposure to toxins can lead to autism. And you obviously get that when you have underserved communities, and I would certainly consider the Native Americans. As it relates to diabetes, diabetes is a condition of diet and exercise. Okay, 90% of diabetes is type 2. Diet, exercise, and medication. So food deserts and lack of access to high quality foods, you're gonna get diabetes. If you live in an area where you don't feel comfortable exercising, or where exercising isn't promoted, where you're too busy doing other things to have time to exercise, it's going to lead to higher issues higher incidence of diabetes. And then medication, if you don't have access, diabetes, if it's controlled, can be much less harmful to the body. You don't have the medication, right, the healthcare access.
Yeah, and if you start looking at some of the reports that coming in, there's over half the states, they label Native American patients as others, not as a unique ethnic group, but as others, which is disappointing for me, because we're not others. We're Native Americans, and when you don't have the right data, does that, Dr. Brooks, does that play a role in how we treat the pandemics going on, either with the COVID or even the diabetes or autism that's happening inside Indian country?
So from the discussions today, data informs, data directs, data provides crucial information. And I also would say that it implies that somebody cares about you. The fact that you're an other, there's an implication in that. I'm just going to leave it at that. And so I think that leads to being neglected. So I concur with the need for data on the Native American population.
In fact, I had to fill out a deal the other day for my son, and it didn't have Native American as a race, and it had others, and it said explain, and I put First Americans. So it was frustrating to me, but because it shouldn't happen. Dr. Brooks, I appreciate it. As I said, Madam Chair, I appreciate you holding this hearing. I appreciate you working with Congressman Burgess on it, or Dr. Burgess on it. I hope when we have another one, as I said, work with me, please, and let's get a witness from Indian country. And with that, I'll yield back.
The gentleman yields back. I will certainly work with you. And I think you working with Mr. Lujan together will really strengthen the case as well. So thank you very much. And we're all praying for your son. And I think our prayers are being heard. So thank you very much.
Thank you. Thank you.
Yes. The chair is happy to recognize the gentleman from Vermont, Mr. Welch, for his 5 minutes questions. You need to unmute. Are you unmuted?
I'm unmuted.
There you are. Okay.
Thank you. Thank you very much. First of all, Mark Wayne, I certainly support your effort, and I know our chair, and I'm sure ranking member will as well. It's a great idea. Second, I want to thank you, Madam Chair, and also Dr. Burgess for your very eloquent opening statements that I think put this whole hearing, this very important hearing, in perspective. And number three, the witnesses have been really tremendous, and I thank them. I want to go back to something that G.K. Butterfield asked, and it was about poverty versus racism. I think it's very apparent that with COVID and the extraordinary impact, disproportionate impact it's had on Black and Brown people, it's raising the question about why. And we've been discussing that. But it's also in a context where we have had the horror of Minneapolis and the murder that occurred there, where we had a man who was bird watching in Central Park, accused because he was an African-American of a violent attack. And then we also had that young man jogging in Georgia who was shotgunned to death. And what is clear is that this question of poverty and racism is now a very active question in our country, or should be. That behavior that was not just an incident of a rogue police person, but it was other white individuals against very innocent African Americans, has ripped off the cover of racism. And we don't have in this country a social insurance program that helps Black, Brown, white, or Native Americans who don't have the income when, through no fault of their own, something happens like COVID. The social insurance for the health care that's universal, the child care, the family leave, and so on. And that's an ongoing debate in Congress. But Dr. Brooks, I'm going to go to you first. You said something that really captured my attention, that there's also an element called racism. And it's time, in my view, that we talk about that. And I would ask you to elaborate on your statement, because as I heard what you said, it was that because of the color of the skin, people were just treated differently. And I turn to you and then would like to hear from Dr. Boyd about that as well. Thank you.
400 years of institutionalized racism, starting with slavery, which was encoded in the Constitution. We had to pass an amendment to remove it. We had to have civil rights legislation in 64. We had to have the Voting Rights Act in 65. Right now, my primary concern with the upcoming November election will be voter suppression. All of this is directly linked to racism. And it's interesting because the worry is now if African Americans have their chance to speak, what may happen? It was against the law to teach a Black person to read. It's ingrained in the fabric of America. To me, the first step in removing this stain in the fabric is to talk about it. Mm-hmm. And as the loss of life of George Floyd occurred, maybe there is some good to come out of it. My personal belief is watching someone get suffocated for 8 minutes and 46 seconds is just unprecedented.
Right.
You
well,
shot,
thank you.
You die, and then you get shot. That's less than a second.
Well, thank you so much. I want to hear from Dr. Boyd, and I only have a little time, but I really appreciate your testimony. Dr. Boyd?
Yes, we also have to think about racism and how it functions structurally beyond just how it functions as individual prejudice. Structural racism is what drives systematic changes in how populations are treated. These are things like the distribution of insurance access in this country or the distribution of clean water access like we talked about. Those are major things that determine how racial and ethnic populations access services and vital supports and resources that are distributed by race. That's not just a prejudice, that's baked into our laws. And that's something that we have to confront.
Mr. Roy, do you have anything to add on this, in your view, on what our other two witnesses have said?
Mr. Roy, do you hear us? You need to unmute. I don't think he hears us.
All right, my time is up, but I want to thank our witnesses. This is tremendous. We've got a lot of work to do.
I agree with the gentleman. We have a great deal of work to do. The gentleman yields back.
Madam Chair. Madam Chair.
Yes.
Can we see if Mr. Roy can hear us for future questions? He can. Okay. Thank you, Madam Chair.
I don't know what he's motioning to us. Can you hear us, Mr. Roy? You can. We can't hear you. It's a pleasure to recognize the gentleman from North Carolina, Mr. Hudson, for his 5 minutes of questioning.
Thank you very much, Madam Chair, for holding this very important hearing. And thank you to our expert witnesses for the time you've given us today. I think it's been an excellent discussion. As you may recall, a month ago at our last hearing, I asked for this hearing and noted that in my experience, particularly in my district, minority communities are experiencing gaps in outcomes. So I'm very appreciative of this opportunity to talk about this today. Across the nation, there's alarming data that people of color are more likely to be affected by coronavirus than white individuals. Native Americans are 5 times as likely. African Americans are 4.5 times as likely, and Hispanics are 3.5 times as likely, according to the CDC. In Fayetteville, North Carolina, a city in my district, leadership at Cape Fear Valley Hospital told me that African American patients make up 57% of their COVID-19 patients. However, in Cumberland County, where the hospital is located, the population is only 34.9% African American. This is not just a local or national issue, it's also global. As Dr. Roy said in his testimony, minorities have been negatively affected in Canada, the UK, France, and Norway, among other countries. This is both alarming and concerning. So I'm happy to see this committee exploring this issue. On another note, I'm very concerned about how economic shutdown in response to coronavirus has disproportionately affected minority communities. I saw this firsthand with problems with access to the banking system among minority-owned business owners in my district. To draw upon, again, the testimony of Dr. Roy, the effects on unemployment and business ownership have been staggering. African-American unemployment has dropped from a record low in late 2019 of 5.4% to 16.8%. Hispanic employment dropped from a record low of 3.9% to 17.6%. And Asian employment dropped from a record low of 2.1% to 15%. Further, African-American owned businesses fell 41%, Hispanic owned businesses 32%. I agree with Dr. Brooks and many of my colleagues who said today that we need more data so that we can dive deeper into these issues. The other thing I've heard from the leadership at the hospitals in my district is the impact of the lack of education and access to resources on disproportionate outcomes with coronavirus. Patients at the hospitals I've talked to have noted that while they may know about coronavirus and are generally afraid of the danger it represents, they do not have access to critical information about stopping the spread of the disease and best practices to avoid contracting it. This isn't for want of trying, though. The hospitals across my district are making concerted efforts to educate their communities about coronavirus, including taking out ads in newspapers that are focused on underserved communities, hosting weekly town halls on radio, posting weekly videos on their websites with updates from CDC. But even with these efforts, it's apparent these educational efforts are not enough. I don't know if Dr. Roy, if we can hear from you, but I'd love to hear from you.
Can you hear me now?
You agree with me? I can.
Okay, great. I just relogged in. Apologies.
Great. Well, Dr. Roy, would you agree with me that the gap in education on coronavirus and how to make preventative measures is hurting our communities, especially communities of color?
Well, it's hard to know. I mean, I haven't done enough work to understand exactly how attitudes in terms of, or understanding education inform, information is transmitting to various communities. I'd say the biggest problem remains, we've talked a lot about nursing homes. I'm glad that Dr. Boyd mentioned incarceration. That's another problem area. We've talked a little bit about Native American communities in particularly Navajo country. These are these concentrated areas where we're seeing the combination of geography, vulnerability in terms of age, pre-existing conditions. That is the nexus where the information in particular needs to go. One thing I would mention, since we're talking about information here, is that a lot of people are telling me, and I think telling your members of your committee as well, that if they have a relative, a loved one in a nursing home, they're not able to access information about that individual and how they're doing, whether they're being adequately quarantined, et cetera, or protected from people who are infected. So, that information is tough to find. Information about testing is hard to find. If and when vaccines happen, that's going to be a challenge too. But one thing I want to mention, we've talked a bit about vaccines today. We have no assurance that there will be a vaccine for SARS-CoV-2 in the next 12 to 18 months, as a lot of people have been talking about. It could be 5 years. It could be 20 years before we have a vaccine for SARS-CoV-2. We've been working on a vaccine for HIV for 40 years, and we still don't have one. We've been working for a vaccine for hepatitis C for even longer than that. We still don't have one. So we have to make sure that we can operate in an environment in which vaccines do not happen in the event that they don't. And we have to operate in an environment where treatments, effective treatments, cures, are longer away than we hope they are. And that's where the information in terms of prevention, physical distancing, et cetera, is so important.
Thank you. Madam Chair, I see my time's expired, so with that, I'll yield back.
The gentleman yields back. The chair now recognizes Dr. Ruiz from California for his 5 minutes of questions. Please unmute.
Thank you. Thank you for this hearing on health disparities. And I too look forward to the tribal policy hearings, specifically on the Indian Health Service that we have talked about, Chairwoman. COVID-19 has shined a spotlight on the inequities that we already knew existed in our healthcare system. You see, I grew up in a trailer park in Coachella, a farm worker community in Southern California, where my family and neighbors did not have adequate access to healthcare. It is what motivated me to become a doctor in the first place, and what eventually motivated me to run for Congress, and most recently motivated me to fight to sit on this very subcommittee, because I want to make our healthcare system better, more affordable, more equitable for everyone. And before I came to Congress, I served as an emergency physician in the Coachella Valley, right here in my district. I conducted an intensive study on barriers to care, and I found that in our region, there was only one doctor per 9,000 residents. For context, the medically appropriate number is about one doctor for every 2,000 residents. So it's easy to see why we have egregious health disparities in historically underserved and minority communities, which of course are brought to the forefront during a public health crisis like COVID-19 pandemic. The fact is that we don't have enough providers in marginalized communities. We don't have enough residency programs there. We know that the two biggest predictors of where a doctor practices is where they are from and where they last trained. So recruiting students from underserved communities and training doctors in those communities is critical. And I worked on creating pipelines to address the provider shortage crisis in a meaningful way right here in the district. Back in 2009, I started the Future Physician Leaders Program, which is a mentorship program for high school and college students who are aspiring doctors from underserved areas where I grew up. I subsequently became a founding senior associate dean of the UC Riverside Medical School and helped pave the way to create residency training programs in our underserved communities. I am the first generation in my family to graduate from high school. So I know the importance of having that type of pipeline support through what can be a difficult process for a kid from Coachella. The Future Leaders Program started with 7 kids after a discussion with me at Starbucks and is now housed at the UCR School of Medicine with over 200 students. And since coming to Congress, I've introduced legislation to help increase providers in these historically underserved communities of color, such as Accessing Higher Education Act, which allows grants to Hispanic serving institutions to be utilized for pre-med mentoring. The Building a Healthcare Workforce for the Future Act would establish a matching state scholarship program to financially support students from resource-poor communities. The Physician Shortage GME Cap Flex Act, which I introduced with my friend Dr. Bouchon, would help extend the time hospitals could have in underserved areas to create these residencies. And the Training the Next Generation of Primary Care Doctors Act, which I introduced with Congresswoman McMorris Rogers, would expand the time that teaching health centers have for training in these underserved areas. My question to Dr. Brooks, Understanding that you have not seen the details of these bills, would you agree that establishing more residency programs and slots in historically underserved areas is one key step to addressing some of the health inequities that currently plague our systems?
Yes, without seeing the legislation and the details, I would support that. The NMA strongly supports directing the young into STEM and developing ultimately into physicians and other healthcare providers, especially if it incorporates African-American children.
Dr. Brooks, the Teaching Health Center program that I mentioned was created in the Affordable Care Act as a way to train doctors in underserved areas with the hopes that those physicians would stay there to practice after completing their residencies. And we're seeing that is happening. Would you agree that because of the population that health centers serve in our communities, that expanding that program and ensuring that they have long-term funding stability is important?
I am an example of a National Health Service Corps scholar who went to work in Watson, has been there for 31 years. So I do support that activity. But
it has to be longer than 3 years. It has to be a longer term to provide that stability as well. So my final question, Dr. Brooks, according to the California Healthcare Foundation, while Latinos represent nearly 40% of the total population in California, they only make up approximately 5% of California doctors. From your perspective, what are the reasons that racial and ethnic minority communities are underrepresented in the healthcare workforce?
I think it's exactly what we discussed, not being channeled into STEM, not having the proper education, maybe being intimidated to apply to medical school. So the focus of your program that you have, I think, would be very helpful.
Thank you very much. I yield back.
I'd like to recognize the gentleman from Montana, Mr. Gianforte, but I don't see him. Going once, going twice. Okay. Then we will turn to recognizing the gentlewoman from Michigan, Ms. Dingle, for her 5 minutes. Thank you.
Thank you, Madam Chair. And Ranking Member Burgess, I want to thank you for convening this hearing today. We really need to have this discussion about racial and ethnic disparities in our healthcare system. And we all keep saying that the African-American community is being disproportionately impacted. But Michigan, my home state, is one of the most significant examples in the country. African-Americans are 14% of our population. 32% of the COVID cases in the state have been African-Americans, and 41% of the deaths have been African-Americans. And unfortunately, I've known more of them than I want to admit. We got to do better. Our governor has created the Michigan Coronavirus Task Force on Racial Disparities to seek what the issues are and how we can start to address them. But state level action has to be complemented by strong forward-thinking action at the federal level. And in Congress, we've got to recognize the magnitude of the problem that we face. I also want to follow up on Mr. Roy's concerns about Medicaid. I agree we need to invest more in getting people home in community-based services. And that's why I fought to increase dedicated funding for HCBS. And we put it in the HEROES Act in the House, included a 10-point FMAP increase specifically for HCBS. And it's my hope that the Senate will do the same when they take up the HEROES Act, which I hope will be sooner than later, because it's something we have to do. But my questions right now are for Dr. Boyd. Dr. Boyd, in your testimony, you discussed the need to expand programs like Medicare and Medicaid to address the health inequities that have been so apparent in this COVID pandemic. And it's backed up by evidence, as I just talked about. And also, in my state of Michigan, 37% of the uninsured are people of color in Michigan. States don't have the resources to meet the healthcare needs that they have during this pandemic. In spite of, my state, in spite of record rainy day funds, including $1.2 billion in Michigan, states are having to make hard choices about how to address their budget shortfalls, especially with states like mine that have a balanced budget requirement. If we don't act, we are going to be facing scary, significant and I don't know what the impact will be on these budget shortfalls. Dr. Boyd, how would significantly increase emergency federal funding for Medicaid, like the provisions included in the House-passed HEROES Act, address the need of minority communities hardest hit by the virus?
Two primary things it would do. One, in terms of the COVID pandemic, it would increase access to testing, hospitalization, and any needed treatments. And two, it would increase access to primary care services that would help treat the chronic, undertreated, and underserved medical conditions that communities of color are disproportionately plagued with.
And I should have asked this question first, but what are the risks to communities of color as all of the states are facing these budget shortfalls? We're not passing the HEROES Act, and they're really making tough decisions that they shouldn't have to make. Dr. Boyd?
All right,
what are the
mute. The risk of the budget shortfalls is that we'll also lack enough supports to support all of the other public and social service functions that our tax dollars pay for. So we've been talking today about social determinants of health, but many social determinants of health are supported. Nutritional programs, workforce placement programs, childcare programs are supported by our tax dollars. And without those dollars, those social determinants of health are at risk too.
Thank you. Dr. Boyd, you've discussed the need for universal workplace protections, including personal protective equipment. Without these, we know we're going to see another surge in cases as Americans begin to go back to work. We've seen the impact on workers of color in places like meat packing plants when they're forced to work without PPE or basic protections. How will this lack of workplace protection further compound the racial health inequities if not addressed?
To make it safe to reopen our economy, we have to make sure that workers, particularly essential workers, have mandated paid sick leave. They have hazard pay when they go in. They have access to protective equipment. These are things that'll keep the supply chains open, that keep our economy running. We have to make sure it's safe for folks to go into an indoor workplace before we ask them to take that risk, because asking them to take that risk is why we have higher rates in our communities of color.
Thank you, Dr. Boyd. I just want to make one observation, Madam Chair, that 3 months ago, we didn't think a whole lot of people were worth even paying $15 an hour. And now our country is dependent upon these very people that we're talking about, who are only being paid $15 an hour and not given PPE equipment. And we need to think about the value of our frontline workers to all of us. Thank you. And
the gentlewoman yields back. It's a pleasure to recognize the gentleman from Georgia, Mr. Carter, for 5 minutes.
Thank you, Madam Chair. Can you hear me okay?
Very well. Very well.
Oh, good. Thank you. Thank you. Thank you all for participating. This has truly been a good hearing, and I appreciate it very much. Dr. Roy, I wanted to start with you. During the discussion today, you've in your testimony, you've said that the economic shutdown has exacerbated health disparities. I know that in April you released a plan of how we could safely reopen the economy. How do you anticipate that those ideas would be helpful and beneficial to minority communities?
Well, thanks, Mr. Carter, for bringing that up. And just for reference, it's in the written testimony, but the plan is at freop.org, freopp.org, and I believe the title is something like a new strategy for reopening the economy, even during COVID-19 pandemic. And the reason why it's titled that way is because we're very concerned that we're all waiting for a best case scenario, that there's a vaccine or a treatment and boom, everything can go back to normal. But what if we don't? What if we can't get a vaccine in the next 18 months? What if a treatment doesn't arrive that's really effective in the near term? Then these disparities will persist over time and become even costlier. Imagine if the entire next school year becomes difficult to execute on. So for all those reasons, our plan really focuses on three areas in particular, I'd say. First, let's make sure we're focused on nursing homes and the at-risk populations, the elderly and people with pre-existing conditions, cardiovascular and endocrinological conditions. Secondly, let's safely reopen schools and let's safely reopen workplaces for where it's feasible where it's going to particularly help those low-income hourly wage workers who right now have lost their jobs because their jobs have been defined by the government as non-essential, and their livelihoods have been defined by the government as non-essential. And that's been a huge problem right now in terms of widening disparities. So the plan talks about that in terms of how you can strategically increase testing and use and reopen businesses where they are able to safely reopen and take into account the latest data on cleanliness, safe practices, et cetera.
Let me ask you something. It's been said that, if there's a silver lining in this pandemic, it may be telehealth. It's been said that we've had 10 years of progress in 1 week in telehealth. How can telehealth and the expansion of telehealth in the minority communities, how can that help to resolve some of these racial disparities?
Well, listen, telehealth absolutely can make a difference in terms of getting timely access to care for the kinds of care that can be administered in a remote setting. But there's a lot of care that can't be administered in a remote setting. And so it's very important to be aware of that. And this brings us back again to Medicaid. I've talked a lot today about how access to primary care, management of chronic diseases, access to testing, all that is challenging in the Medicaid program because of the way Medicaid pays doctors and providers. I want to mention something else, Mr. Carter, if I may, which is let's talk about the dual eligible population, right? The elderly, low income population that right now is in this completely dysfunctional system where they have two different federal programs, one a federal state program, one a federal program that don't really interact with each other that well. One thing we talk about in a different free-op policy paper called Medicare Advantage for All is giving states more flexibility to integrate their dual eligible populations into Medicare Advantage-like plans that are available to some today, but could be much more widely adopted so that low-income vulnerable seniors can get integrated coverage and better access to that primary care that they need. That's something that's really important that Congress could do something about.
Right. Thank you. Dr. Brooks, I wanted to ask you in the minute I've got left, in your testimony, you talked about the importance of considering social determinants if you want to address health disparities. And one issue that I've been working on is ensuring that Medicaid beneficiaries have access to non-medical transport. In fact, Representative Cardenas and I have introduced Protecting Patients Transportation to Care Act, and that codifies the NMET, the EENEMT benefit in the Social Security Act. We've seen some progress on this bill, and I hope that we're going to be able to get it passed. It needs to be passed. Can you talk about the importance of addressing things like transportation and other social determinants in order to tackle health disparities?
Yes. So transportation is a major barrier to achieving access. We have transportation service at my health center, but now they're shut down because of COVID. So non-emergency medical transportation would be very helpful. And just very briefly, the telehealth. So telehealth is very important. I mean, that reduces the need for transportation. It's suboptimal to a physical evaluation, but it's much better than no evaluation. So addressing transportation, I think, is very important. It will lead to better outcomes.
Good. Again, thank all of you for your participation today. Thank you, Madam Chair, and I yield back.
Thank the gentleman. He yields back. I now would like to, I don't see, oh, there you are. Recognize the gentlewoman from New Hampshire, the patient gentlewoman from New Hampshire, Ms. Custer, for your 5 minutes.
Thank you so much, Chairwoman Eshoo, for holding this important hearing today. It's not possible to overstate how important it is that we address systemic racial disparities in our healthcare system. And COVID-19, as well as the pain and violence inflicted upon our Black neighbors, friends, colleagues, and fellow human beings, has brought to the forefront of our conversation the impact of racism on health and well-being in our communities of color. We know, and we've heard a great deal today, that the COVID-19 pandemic has disproportionately impacted communities of color, and we have widespread evidence of institutional discrimination leading to poor health outcomes. As a member of this committee and the Black Maternal Health Caucus, we've explored and legislated on the racial disparities in maternal health, but it goes beyond maternal health, and I'm very hopeful that today's conversation will lead to more work by this committee on addressing racial health inequities and social justice. Here in New Hampshire, white people account for 90% of the population, but they're a shrinking proportion of our COVID-19 cases. Just weeks ago, white people made up 81% of the COVID population in New Hampshire. Now that number's dropped closer to 75%. But meanwhile, the proportion of cases among Black and Latinx Granite Staters has grown. Among Latinx, who make up 3.9% of our population, they now account for 10% of COVID cases. Among our Black community, that make up only 1.4% of our population, they now represent 6.3% of the total infections from COVID-19. So these numbers do not lie. Manchester, New Hampshire Health Department Director Anna Thomas recently said, "The health of our community is only as strong as the health of our most vulnerable residents, and by any measurement, we must do better." She also recently requested citywide data. And without this data, it's difficult to understand where to target resources that are needed. Dr. Brooks, can you provide some examples of initiatives that could help turn city-level data into actionable insight and connect with community organizations to provide resources?
Yes, so there is modeling. There's modeling software that if you provide data and accurate data and up-to-date data, it can tell you where to direct healthcare services, where to direct testing, where to have like food supply giveaways. So that's one way. And the other way would be to have, again, standardized data reporting. If we have standardized data reporting, everyone will be reporting the exact information, and then it will be apples to apples.
Thank you. And I wanted to just address the vaccination inequities that has come up. Can you speak to the root causes of racial disparities? I think you have mentioned this in vaccinations, but as we look ahead, what are some suggestions that you would have for making sure that we have equitable distribution of vaccinations? And I just quickly would mention the bill that I'm leading with Congressman Hakeem Jeffries, H.R. 7104, Coronavirus Vaccine Development Act, requiring the administration to plan ahead for the coronavirus COVID-19 vaccine distribution. What suggestions would you have in the limited time that we have left?
Yes, I note that. I would say, first of all, it helps if states or the federal government mandate that if you do not get vaccinated, you don't get, let's say, WIC or SNAP. That is helpful. Number two is, again, access. So Medicaid expansion is crucially important in terms of children and adults, for that matter, getting vaccinated. And lastly, I would say messaging. I mean, we know how to sell soap or fabric softener, but we really need to message into the communities the importance of vaccination. And as a vaccinator, as a pediatrician, the safety and efficacy of the vaccines that we have.
Great, thank you. I do have one more question on incarcerated workers, but I can submit that for the record. Thank you. Our incarcerated population that's been hit so hard.
I thank the gentlewoman, and she yields back. I now would like to, let's see, do we have any Republicans that have not been, that are back on, that haven't been, I don't think so. Mr. Griffith,
I don't see any, Madam Chair.
Yeah, I don't either. Then I will recognize the gentlewoman from California, Ms. Barragan. And thank you again for inviting Dr. Brooks. You're recognized for 5 minutes, and make sure you unmute.
Great. Thank you, Madam Chairwoman, and thank you to all our panelists today. I represent the communities of Compton and Watts. It's a very working class community, almost 90% Latino and African American community combined. I've seen firsthand what COVID-19 has done in our community and the systematic racism that's happening across a lot of different areas, including healthcare. Dr. Brooks, in your testimony, which I thought was very powerful, you asked the prominent question, why is it we're seeing the glaring differences in dying from COVID-19? And in that, you respond and talk about social determinants of health, which I couldn't agree with you more about. which is why I introduced a bill called the Improving Social Determinants of Health Act, which would provide funds to the CDC to establish program focus specifically on social determinants. It would also establish a grant program for local public health departments to tackle this issue. Dr. Brooks, can you again highlight for us the importance of addressing social determinants of health and why Congress needs to do more and act in this area? Specifically, can you maybe explain what social determinants of health how they've impacted your patients in Watts and what it means for long-term health consequences of people in our community and how these conditions are impacting our community's fight against COVID-19?
Yes, thank you. I would like to pause just a second. Thank you very much for the warm introduction and for the work you're doing in your district. You represent my employer in your district, and you do great work on the federal and local level.
Thank you.
Social determinants of health tend to determine about 40% of health outcomes, which is more than genetics or access to care / medicine / surgeries or treatments. So it is the most important determinant of how you will be in terms of your life as it relates to health. So your focus with legislation on the social determinants of health gets directly at the issue. And I might add, if passed or if that focus occurs, it'll help all Americans. I think that's really very important. It'll help African Americans, but it'll help Latin Americans, Latinx, Native Americans, etc. So social determinants of health, main one that I see really in our area is food insecurity. I'm really focused on diet. If you eat well, you will likely be more healthy. Then I'll also say mental health. It was mentioned allostatic load. When you're stressed, you release excess cortisol, which is a marker for inflammation, and you have worse outcomes. And then education, the focus was there. If you have good schools, if you have a focus on education, and for us STEM, then you will have better health outcomes. Education is directly linked to health outcomes.
Great, thank you, Dr. Brooks. Next, I want to talk and discuss the importance of research endowment program at the National Institutes of Health on minority health and health disparities. This is a program that funds to the endowment of academic institutions across the country, institutions such as Morehouse School of Medicine, Atlanta, SUNY Downstate Medical Center in Brooklyn, Florida International University in Miami, and Charles Drew University in my very own district. The goals of the program include promoting minority health and health disparity research capacity and infrastructure, things like increasing the diversity and strength of the scientific workforce and enhancing the recruitment and retention of individuals from health disparity populations that are underserved in the scientific workforce. Dr. Brooks, in your testimony, you state that poor reporting of data, which initially masked the fact that the disease was disproportionately affecting Black communities, remains a problem even as states move to reopen their economies. Do you agree that providing funding to academic institutions to encourage research in minority health plays a crucial role in reducing the minority health disparities, including during this current crisis?
Clearly, very interestingly, all of those institutions reside in African American communities. So they have a focus on the community that surrounds them. And they have an academic bent. They do clinical research. They publish articles. So that type of research, that type of funding and directed funding would reap great benefits in terms of the data that would come from it and the actions that would come from that data. So I highly endorse that.
Well, thank you, Dr. Brooks. I recently introduced a bill called the NIMHD Research Endowment Revitalization Act with Congressman Carter. It's a bipartisan bill. I'm happy to say that the Senate has passed this bill. It's onto the House. And so it is upon us to move this in the House and get it through to the finish line. So it will be one part of helping address this crisis. And with that, Madam Chairwoman, I yield back.
The gentlewoman yields back. I now would like to recognize the gentlewoman from Delaware, Ms. Blunt Rochester for your 5 minutes of questions. And are you unmuted? I don't think so. You need to unmute.
I'm unmuted.
There you are.
There you go. Thank you, Madam Chairwoman, and thank you to the panelists. This has probably been one of the most important panels that we've had, and around the country and in my home state of Delaware, and as others have mentioned, we've seen the disproportionate impact of COVID-19 on communities of color. As one of my favorite writers and activists, James Baldwin, said, "Not everything that is faced can be changed, but nothing can be changed until it is faced." This pandemic brought to light the health disparities that have long existed in our country, and we have this very moment to really act and address them. The root of health disparities are complex, as all of you have shared. There have been a lot of conversations about the social determinants of health on this call and or on this Zoom. Some state Medicaid and children's health insurance programs are exploring opportunities to address the social determinants of health, like access to safe, affordable housing, availability of healthy food and drinking water, and healthcare services. But there's not clear guidance on how states can leverage existing or waiver authorities to do so. That's why my colleague, Congressman Bilirakis, and I introduced a bipartisan bill, HR 4621, the Caring for Social Determinants Act, to let states know what works and how to deploy the strategies, particularly for the pediatric population. Dr. Brooks, if more state Medicaid programs knew how to build strategies to address the social determinants into their demonstration projects and contracts, could we reduce health disparities? And more specifically, can you give us some examples?
So the answer to your question is yes, it would reduce disparities. An example I would give would be one of those that was mentioned earlier, transportation. If there were more Medicaid coverage of transportation, you would see better outcomes. I would also say integrating mental health. In LA County, mental health and physical health are separated. So in integration into the physical health side, the medical side of behavioral health services as a demonstration project, funding and however you see, I believe would show directly improved health outcomes, which I want us to remember. That's the goal. Healthier people.
Exactly. And you actually shifted into what I wanted to talk about next, is really the toll that chronic stress from exposure to law enforcement violence has on the Black community. Chronic stress can lead to diseases like hypertension and heart disease, as we know, both are linked to the COVID-19 mortality. Because of existing mental health disparities, we know that if we don't get the treatment or if there's stigma attached, there will be challenges. And I'm working on legislation to look at health consequences of law enforcement violence on communities of color and reduce barriers these communities face in accessing mental health services. Dr. Boyd, are there additional research gaps in our understanding of chronic stress on Black Americans that Congress should be focused on or should be filling? And what still do we need to do to learn about the intergenerational nature of stress and trauma?
Thank you for that question. One of the gaps you outlined there, we have yet to fully acknowledge and address police violence as a public health crisis in this country. We need to both study it that way, and we need to equip our public health departments to address it in that way. So one of the gaps that we have is better understanding some of the health impacts of police violence. We know that police violence increases risk, as you said, to illnesses associated with chronic stress, like hypertension, diabetes, heart disease, cancer. We also know it has a disproportionate impact on mental health for all African Americans who are witnesses. So I think it's really paramount that we focus on police violence, particularly at this time.
Thank you for that answer. I was going to talk about cultural competency as not just a program, but an underlying pillar to advance health equity. It's something I would really like to follow up with you on, with both of you on, because I feel this issue of mental health and healing, particularly when you marry COVID on top of the issues that we're dealing with right now and what we're witnessing. For many of us, these are not new issues. So much so that even as Deputy Secretary of Health and Social Services, when I was working in Delaware years ago, I got high blood pressure just trying to create an Office of Minority Health. So we need to deal with these underlying issues. And I thank you all so much for your work, Mr. Roy, as well. Thank you. And I yield.
Thank you. The gentlewoman yields back. And now it's a pleasure to recognize the gentleman from Illinois, Mr. Rush, for your 5 minutes. And make sure you unmute yourself. The gentleman is recognized. Can you hear me? You need to unmute, Bobby. He's been waiting for so long, too. The gentleman needs to unmute. Can't hear you.
I'm not sure he can hear us.
He can't, I know, I'm trying to motion to him. Why don't we see if the staff can assist Mr. Rush? And we have 4 members that are with us, that are part of the full committee. And according to our rules, they can wave on to the subcommittee. And the first one that I wish to recognize is the gentlewoman from Colorado, Ms. DeGette, for 5 minutes.
Thank you so much, Madam Chair. Thank you so much. I really appreciate you allowing me to wave onto the subcommittee, and I want to thank the witnesses for their testimony. Your insights are really, really helpful to us as we confront the coronavirus challenge, and particularly the issues of racial disparities. And I just want to say my district is a highly urban district. It's the city of Denver and some other areas around it. According to Denver Health, the Latino population accounts for 58% of COVID-19 cases in Denver, while only making up 30% of Denver's population. And of course, when you look at the health risks, they're even greater now during the pandemic. And so I want to ask a couple questions, and I know some of the members have touched on this, but I'd like to ask a couple of follow-up questions. As the number of underinsured or uninsured Americans has increased because of the economic impact of COVID-19 with people losing their jobs, people of color are going to face a greater risk of morbidity and mortality associated with the disease due to delayed or foregone treatment. Dr. Boyd, can you talk about the importance of ongoing healthcare coverage for Americans, and especially coverage for minority populations when it comes to facing then a great health challenge like this?
Yes, because we've linked healthcare to employer-based health insurance. When populations lose their job, and we know nearly half of African Americans have lost their job as a result of COVID-19, they lose their health insurance. So ensuring that insurance is not a barrier to healthcare is really critical, particularly for African Americans, Latinx, and Indigenous populations who have the highest rates of uninsurance and underinsurance, less insurance than they need to meet their health needs.
Right. And Dr. Boyd, I also wanted to ask then, if somebody loses their job and their health insurance, then they start to get sick, it would seem to me, as a layperson, but you're a doctor, that it would make it even less likely that that individual would try to go for medical treatment if they had symptoms of COVID-19, causing potential even greater illness.
Absolutely. The evidence indicates that your economic status informs how you utilize healthcare. And so if you don't have sufficient financial resources at home, you stay home from healthcare as well, which makes you more likely to present later in your case, which in the case of COVID means you may be more severe and more likely to suffer a bad outcome.
Yes. Now, you know, another issue I've been working on a lot is, and actually several of our witnesses, I think Sir Roy and also maybe Dr. Brooks talked about this, is COVID is going to be around us for a long time, and we need to be able to learn how to deal with these issues. And part of it is going to be testing and contact tracing. Congresswoman Shalala and I are working on legislation to make coronavirus tests free for anybody with employer-based insurance or a plan under the ACA. And I know this has been included in several of the relief packages, but I'm worried what's going to happen with uninsured individuals if they don't want to pay for testing or treatment. Then how are we going to do the testing and then the subsequent contact tracing? And will this cause just a greater magnified effect? Dr. Brooks, I'm wondering if you can talk about what's known about access to testing and tracing among minority populations.
So first of all, your presumption is correct. Those that are uninsured will be less likely to get tested. And we also need aggressive testing and contact tracing. So right here in California right now, we do have something called presumptive eligibility, where some people that are uninsured can get tested. But I would say that helps, but that's a Band-Aid. Okay, we need federal legislation that would cover testing for everyone and aggressive contact trace. We have all these unemployed, 16% unemployment rate. Employ them, give them a living wage and have them do the contact tracing.
Right, because even if you can give someone a free test, if they do the contact tracing, those people may not want to go get tested. So it just magnifies. Thank you very much, Madam Chair, and thanks for letting me sit on. Appreciate it.
You're always welcome. So the gentlewoman yields back. I'm going to go back to the gentleman from Illinois, Mr. Rush. Thank you for being so patient.
Can you hear me now?
Yes, I can hear you very well. Thank you.
I have been diligently listening and since the beginning. So I'm glad that I'm on. And I want to thank you for having this hearing. As a Black man in America, because of episodic racism and systemic racism, I find myself an unapologetic, angry Black man, even after all these decades of fighting on the front line for freedom, justice, and equality. And if not for my faith, I really don't know where I would be. Dr. Moore and I fully agree that we as a nation, and certainly we as a Congress, are at risk of becoming data addicts, addicted to more and more data, where we already have sufficient data to act courageously and willfully to solve this endemic problem. I also absolutely agree with you, Dr. Boyd, when you stated that according to one study, eliminating segregation would erase Black-white differences in income, education, and unemployment. A recent published investigative piece found that in Chicago, lenders have invested more in a single white neighborhood than all the Black neighborhoods combined. And as you eloquently stated, this disparities snowballs to disparities in exposure to air pollution, access to clean water, employment, educational opportunities, and many other impacts that are clearly the bedrocks of systemic racism. Dr. Boyd, can you expand on how Congress and the federal government can best take action to address the underlying and ongoing residential segregation that is all too widespread in our society?
Thank you for those powerful words. Yes, I think one thing that I'll underscore that you mentioned is that we know communities of color are disproportionately exposed to toxins and pollutants in the air. That's because they are concentrated in communities that have been shaped by redlining, segregation, white flight, suburbanization, and zoning laws that allow industry to live right next to where kids play and where schools are. We can't allow that anymore. So I would love it if our nation's lawmakers would respond to the disproportionate environmental racism suffered upon communities of color. That one study even showed increases that exposures to particulate matter in the air, like air pollution, can increase the COVID-19 mortality rate 15% more. So it's not just overall, environmental racism. It directly affects your risk for COVID-19 mortality.
Thank you. Dr. Brooks, I have a bill, the Communities Act, which will increase loan forgiveness for doctors who practice in underserved communities. What impact will a program like this have on increasing the number of physicians, and particularly physicians of color who serve in medically underserved communities?
Loan repayment would be a great support mechanism to allow primary care physicians to come into medically underserved areas. As you know, the debt of an average debt is somewhere around $250,000 coming out of medical school. So that would drive the younger ones to give care in an underserved area. And the younger ones have new energy, new ideas. And number two, where you start working, you're more inclined to stay. There is a shortage of primary care providers in the underserved communities. Fairly Qualified Health Centers, one of which I am the chief medical officer, we're constantly looking for physicians, and specifically physicians of color, because again, as I stated earlier, physicians of color provide better care to African Americans. And there's also a study that showed they are less likely to have implicit biases related to race.
Dr. Boyd, you talked a few minutes ago about the impact on police misconduct, police violence, and a public health issue. Can you expound upon that police violence and a public health issue?
Yes, particularly during this COVID-19 pandemic, we have to acknowledge the intersecting forms of violence that are facing communities of color. We've talked about the violence of segregation, the violence of disinvestment in their communities, but we also have to talk directly about state-sanctioned violence by police that we know drives up increased rates of mental health conditions, for kids of headaches, sleeping trouble, trouble with school performance, and for adults, for risks of chronic disease. If we don't address that, then we are leaving unaddressed some of the drivers that are contributing to higher rates of COVID-19 mortality right now.
Thank you, Madam Chair. I yield back.
The gentleman yields back, and I thank him. I know that Congresswoman Schakowsky and Congresswoman Clark were both waving on. I saw them earlier, but because I don't see them now, excuse me, I'm going to recognize the gentleman from Arizona, Mr. O'Halloran. Welcome. Wonderful to see you. Are you unmuted? You have to unmute.
Same here, Madam Chair.
Here you are.
Appreciate it. This is
wonderful.
Thank you for allowing me to wave on, and this has been an outstanding committee meeting. I'm very pleased that we were discussing such an essential topic at this point. Quite frankly, the response to the COVID-19 pandemic has not been adequate for our tribal nations, our communities of color, and basically across America. For our tribal nations, of which I represent the Navajo and the White Mountain Apache out in Arizona's 1st Congressional District, up until very recently, Navajo Nation had the highest per capita COVID-19 infection rate in the nation. This was just surpassed by the White Mountain Apache, also in my district. White Mountain Apache currently have over 1,300 cases of COVID-19 out of an enrollment of just 12,000 people. This is a small tribe that is, I just talked to the chairwoman this morning. It was just sad to have that discussion. But the common thread amongst many of these communities of color, tribal nations, It's the deserts. It's the healthcare that's in those communities. It's the food, the health, the infrastructure, the housing, all of those deserts that are out there. I'm looking out at a desert right now, but I'm close to a store. I'm close to healthcare. I have banks around the area. These areas don't have that. I grew up on the west side of Chicago, and Representative Kelly and Representative Rush know that well. And I have to tell you, I'm just in shock. And we have bills to make sure we get some epidemiology information for tribes, but it has to go so much further to address the critical issues of racial segregation, racial impacts, and the lack of this Congress and this country to acknowledge that we have trust in tribal obligations and treaty obligations. This pandemic has exposed what those of us who live in rural and underserved America already know. We lack access to healthcare providers. It is estimated that over 100,000 homes on tribal lands lack access to running water and adequate sanitation infrastructure. On Navajo, roughly 30% of the population lacks access to running water at all. I introduced a bipartisan bill to address this very issue here, and I hope to see it move in a future House package. Before the COVID, the unemployment rates across the district, Navajo was at 40 to 50% unemployment before COVID, and the White Mountain Apache was close to 80% unemployment. Dr. Boyd, thank you for noting in your testimony that Native Americans are 19 times more likely to have access to clean drinking water than white Americans. Now, I also want to ask you a question. Do you believe that better reporting and information sharing of illness in minority communities can inform better the treatments and improve health outcomes and create better policies? Specifically, how can we do this to ensure that we can identify issues and allow them to be addressed in a culturally appropriate manner with federal support when and where it is needed? Thank you.
Yes, just to bring up the clean water example that you brought up, which is so devastating for Indigenous communities, that's not a function of what we don't know. We already know that residential segregation onto reservations and that public divestment in the Indian Health Service has left so many Indigenous communities without the resources they need, including basic resources like clean water. We don't need further data to say we need to further invest in Indigenous communities and their healthcare infrastructure to further address what their needs are. Obviously, though, data is really important, and I'll only underscore one more point, which is that Indigenous communities are often left out. If they aren't counted as other, they aren't counted as all because their populations are often very small, which is, again, a function of genocide in this country. So we also have to be committed to counting at smaller rates who's affected and how, so that we make sure we always encompass what's happening with Indigenous communities.
Thank you, Dr. Dr. Brooks. In your testimony, you mentioned implicit that bias training is necessary for physicians and all healthcare professionals. I believe it is also implicit for the Congress of the United States. When patients are subjected to bias treatment from their healthcare provider, how does that impact their decisions to seek care in the future? And does it also contribute to poor racial and tribal health care outcomes?
Yes, if a person feels that they have suffered from implicit bias and therefore poor care, they're maybe less likely to go seek care the next time. So, and that can happen with the Native American population, certainly. So that's why it is critically important to have implicit bias training, because then that's just one hurdle that we can get past and now get to the more mundane treating illness.
Thank you, Madam Chair, and I yield.
The gentleman yields back. It's always a pleasure to have you join us. I'm just going to do one more call out for Representative Schakowsky and Representative Clark. I don't see them on the screen. I'd like to bring the hearing to a close. Thank you, Mr. Griffith, for being with the committee from before the gavel went down to the rest of the gavel, the gavel going back down again, as well as Ms. Kelly. You've spent hours with the committee, and I wanted to acknowledge that and thank both of you. And as I said, Mr. O'Halloran, you're always welcome. To our witnesses, I think you have been so highly instructive to us today. We have an enormous amount of work to do. But with this enormous challenge that we have, and they are enormous challenges, I think come enormous opportunities. And I think that that's the set of bookends. I'd like to recommend for those members that represent Native Americans that I'd really like to see you come together and hopefully put a package of bills together. We have members from both sides of the aisle that are so eager to address the meagerness, the shamefulness in the Native American community and the tribal nations. To both of the doctors, you've been outstanding witnesses. We have learned a great deal from you. And I know that you will continue to make yourselves available to members as we seek to put together legislation that will be highly effective and help turn the page of shamefulness in our country around. This is our responsibility. I believe that there is the political will in our subcommittee. It's an outstanding subcommittee on both sides of the aisle. And to Mr. Roy, thank you once again for being a witness at our subcommittee. You are always welcome, and you gave excellent testimony to us as well. So what I'd like to do is to submit the following statements for the record. And I also want to remind members that pursuant to committee rules, they have 10 business days to submit additional questions for the record to be answered by the witnesses who have appeared. So I ask the witnesses to respond promptly. I know you have your hands full, but we ask that that you respond promptly to any questions that you may receive from members. So with that, I'm requesting unanimous consent to enter the following documents into the record. A statement from the Asian and Pacific Islander American Health Forum, a statement from the Association of American Medical Colleges, comments from the American Kidney Fund, a statement from the Association for Clinical Oncology, a Brookings report entitled Race Gaps in COVID-19 Deaths Are Even Bigger Than They Appear, testimony from the Center for Reproductive Rights, a June 10th, 2020 letter from the Alliance of Multicultural Physicians to the FDA Commissioner, Stephen Hahn. In April 2020, Kaiser Family Foundation issue brief entitled Communities of Color at Higher Risk for Health and Economic Challenges Due to COVID-19. June 16th, 2020 report from the Robert Wood Johnson Foundation. A May 2020 report from Families USA entitled The Fierce Urgency of Now, Dr. King's words. Federal and state policy recommendations to address health inequities in the era of COVID-19. A Health Affairs Journal report entitled Disparities in Outcomes Among COVID-19 Patients in a Large Healthcare System in California. A statement from Johnson & Johnson Services.
Madam Chair.
Incorporated.
Madam Chair.
Yes.
Madam Chair. How much longer is your list? I'm happy.
Well, they're not numbered. I'm
happy to waive the remainder of the list, assuming that all of those have also been seen by the minority staff.
With that, the entirety of this list, maybe the staff can tell me if they actually have to be verbally read into the record, or if we can just by unanimous consent place the rest in the record. well, the Republicans agree, according to Mr. Griffith. So
That
I
is
thank
correct.
you, Mr. Griffith, for that. And once again, let me thank the witnesses for your superb testimony. I began the hearing by saying that America is in pain, America is in anger, America is doing something that I think is very healthy, and that is questioning. And that there is really, I think, a coalition of conscience across the country responding to the wrongs that need to be made right. So with your good help, your testimony, and the political will of the members of this subcommittee that I'm so privileged to chair, I thank you. I know that there will be outreach to you, and I know that you will respond. And with that, I will now adjourn the subcommittee, the Health Subcommittee of Energy and Commerce now. Thank you, everyone, and good afternoon.
Thank you.
Thank you.
Thank you.
This is, okay.